You have quorum, Mr. Chair.
Thank you very much. And Member Poirier and Member Kapoor did send their regrets for this evening's meeting. Any declaration of pecuniary interest, including those originally arising from prior meeting? Anyone? Seeing none, thank you. And confirmation of minutes. Can we confirm the minute of December 11th meeting 2017? Carried. Thank you. There were 6 communication items that have been received on the file for the board that are held with Ms. Play. And moving on, I will go to Member Pinnell to introduce the procedural motion. Member Pinnell, please.
Be it resolved that the confirmation of the Chair and Vice Chair report, the verbal report by the Chair of the Board of Health, the verbal update by Dr. Vera Eches, Acting Medical Officer of Health, the harm reduction and overdose prevention follow-up report, the preparing for the legalization of cannabis report, the healthy living, active living, have your say, protecting vulnerable populations through restrictions in marketing of food and beverages report, the Ottawa Board of Public Health Funding and Accountability Agreement 2017 Year-End Results Report, and the attendance at the Association of Local Public Health Agencies, ALPHA, Board of Health Section Meeting Report be received and considered. And be it further resolved that the rules of procedures be suspended to receive and consider a presentation on the subject of options for the recruitment, selection, and appointment of a medical officer of health.
Is that carried? Thank you. And I'll turn the agenda over to Ms. Play for her.
Thank you, Chair. As members are aware, the HPPA requires that at the first meeting of each calendar year, boards of health confirm their chair and vice chair, and our procedure bylaw requires that that portion of the meeting be presided by either the city clerk and solicitor or the board secretary. Hence, the chair is turning the meeting over to me for a few moments. So I will draw your attention to recommendation 1 of report 1, which is to confirm the election of Councillor Shad Kadri as chair for 2018, to be confirmed at the first meeting of each year of its term as required by the HPPA. Is that item carried?
Yeah, carried.
Thank you.
Thank you very much. And moving on to item number 2 of that same item is confirm the election of members Joanne Poirier as Vice Chair for 2018 to be confirmed at the first meeting of each year of its term as required by the Health Protection and Promotion Act. So I know Ms. Poirier is not here, but I did have a conversation with her and she's willing to put her name forward for the Vice Chair, so if it's okay with the board. Can we carry that item?
Yes, carry.
Thank you very much. Okay, moving on to item number 2, which is the Chair of the Board of Health verbal report. We will hold on to that. Medical Officer Health verbal report, again, we'll hold that item. Item number 4, harm reduction and overdose prevention follow-up report. As there is a presentation and 3 members of the public delegation, we will hold that item. Item number 5, preparing for the legalization of medical cannabis. As there's a presentation from staff on that, we will hold that item also. Item number 6, healthy eating, active living, marketing of unhealthy food and beverages, next step. We do have a presentation on that item, so we will hold on to that item. Item number 7, Ottawa Board of Health Public Health Funding and Accountability Agreement 2017 and year-end results. That the recommendation is that the Board of Health of the City of Ottawa Health Unit receive for information the 2017 year-end results and related information as outlined in the report. Can we receive that report? Received. Thank you. Item number 8, attendance at the Association of Local Public Health Agencies, ALPHA, Board of Health Section meeting. The recommendation of the report is that the Board of Health for the City of Ottawa Health Unit approve the attendance of Member Kakish at the Association of Local Public Health Agencies Board of Health section meeting to be held February 23rd, 2018. Is that item carried?
Carried.
Thank you very much, Member Kakish. Item number 9, option for the recruitment, selection, and appointment of a medical officer of health. Again, there is a presentation on this, so we will hold that item. And that's it. So we're back to item number 4, or sorry, 2, which is my report. As I said earlier, welcome to the first meeting of 2018, and it's my pleasure to be selected as the chair for one more year, which is year 2018, and I want to thank the board for showing confidence in my leadership moving forward. I would like to begin tonight's verbal update by recognizing that we are meeting on traditional Algonquin territory. As we meet on this land, I know that Ottawa Public Health continues its efforts to promote reconciliation and to advance the Indigenous health equity in Ottawa. This winter, we have experienced some challenging weather patterns. We know that extreme weather can affect the health of residents. Ottawa Public Health has issued 6 frostbite advisories reminding residents to dress for the weather, monitor local forecast, and walk safely to prevent falls. In mid-January, Dr. Etches and I, along with a few other OPH staff, met with representatives for Hard Rock, Ottawa, to look at ways to work together to minimize the harms of gambling. The meeting was productive. Discussions will be ongoing, and the board will be updated as things progress. As you know, January 31st was Bell Let's Talk Day, an annual event that continues a nationwide conversation about mental health, awareness, and aims to reduce the stigma associated with mental illness at the same time as it raises funds, much-needed funds, to support programs and services. Mental illness affects people of all ages and from all walks of life. Many people living with mental illness report that negative stereotypes cause them more suffering than the illness itself. As a result, 2/3 of those living with mental illness are afraid to reach out for help. On January 31st, Bell donated 5 cents to Canadian mental health programs for various online and telephone interactions. Through this initiative, Bell has supported Ottawa Public Health's mental health programming, including the Have That Talk video campaign. Thank you to all those who joined us as we work together to break down the stigma that surrounds mental illness. I was also honored to be able to start the new year with OPH staff at their annual all-staff meeting. I took this opportunity to talk about some of OPH's successes in 2017 and look ahead to the new year. I see many opportunities ahead in 2018 to improve to communities' health, and I wish and share my enthusiasm for the new year with staff. I was joined by Member Pinnell of the Board of Health and would like to thank her for being with us that morning. Finally, on Wednesday, the Mayor talked about a notice of motion at City Council proposing that we formally ask Ontario's Minister of Health and Long-Term Care for additional investments for mental health and addiction treatment services in Ottawa. I seconded the motion, which proposes a focus on early intervention for children and youth, assisting people with lived experience in system navigation, rapid access addiction medicine clinics and treatment facilities, community-based withdrawal management, and support for primary care physicians to provide appropriate pain management and treatment for opioid disorders. Council will be voting on the Council will be voting on the motion at its next meeting scheduled for Wednesday, February 14th, and I'll keep our board members aware of any developments. So this evening we have a full agenda, so I will conclude my comments at this stage and ask board members if they have any comments or questions. Seeing none, can we receive that report? Thank you, and I'll turn the floor over to Dr. Etches for her verbal report. Doctor?
Thank you. Good evening, bonsoir. I would also like to begin by recognizing that we are on unceded Algonquin territory, and I really appreciate Dr. Levy's leadership around reconciliation and Indigenous health, and I am committed to continue to advance health equity with First Nations, Inuit, and Métis populations in Ottawa. So while we're only 1 month into 2018, I do have updates on local matters, provincial work, and collaboration across the region. Locally, last week there was an increased number of unusual overdoses in our community. According to Inner City Health, the overdoses included severe symptoms requiring 3 to 4 uses of naloxone. And in addition, there were adverse reactions that were neurological in nature, which have been associated with carfentanil. The supervised injection service that Ottawa Public Health runs also had to use naloxone and call 911 more than usual. So Ottawa Public Health alerted our Overdose Prevention and Response Task Force, and we worked with partners to raise awareness of these events, of information about the supervised injection services available, to encourage overdose prevention and use of naloxone. Next, you may have noticed or even experienced yourself that the influenza virus is still alive and well in our community. And although influenza A activity is on the decline, we are seeing higher levels than usual compared to this time of year of influenza B activity. Vaccine effectiveness data was also released just last week, and it shows that while the effectiveness of this year's influenza vaccine against the A strain was low, only 17%, that the vaccine effectiveness against influenza B has been around 55%. So complications from the flu can include pneumonia, hospitalization, even death for people who are more vulnerable, and that's children under age 5, seniors, pregnant women, and people with chronic illnesses and conditions. So residents are still encouraged to get the flu shot, and they can get it through local pharmacies, primary care providers, by appointment at Ottawa Public Health Clinic at 100 Constellation Drive, and new this year, you may have heard about through the Ottawa Paramedic Community Paramedicine Program. Ottawa Public Health has also been notifying these vaccine providers in our area that there is now publicly funded quadrivalent vaccine available. That's a vaccine that was only available for children, and now it's available for adults. That is the only vaccine that contains the strain, the B strain, that is circulating the most at this time. And of course, another defense against influenza is hand hygiene. And as you know, hand washing, appropriate use of hand sanitizer, is one of the best defenses against the spread of infectious diseases in our community. The hospitals have been asking for our help in communicating hand hygiene messages, and we've been supporting them with this messaging. And we continue to remind all residents that Ottawa's health is in your hands. We're also pleased to continue to support our hospitals with their smoke-free policies. So as of January 1st, the Smoke-Free Ontario Act now makes the outdoor grounds of all hospitals 100% smoke-free. We've been working with our partners in bylaw and the hospitals to implement this smoke-free hospital grounds. And another piece of positive news around smoke-free places pertains to the constitutional challenge that was put forward on our water pipes in public places and workplaces bylaw. You may recall that this challenge was filed with the courts, claiming that the bylaw violated rights under the Charter of Rights and Freedoms. And I'm pleased to say that while we were expecting the hearing this month, the challenge has been withdrawn. And lastly, on the local front, in follow-up to the last board meeting, we are in consultations right now about how to work with our partners on bed bugs to let the province know what we need in our community. And also, Ottawa Public Health is preparing the annual service plan submission to the Ministry of Health and Long-Term Care that will outline our budget as approved by you in December. And that's a March 1st deadline that we're working towards. Provincially, the Ministry of Health and Long-Term Care is signaling that they will move forward with regulations for personal service settings, also a topic of interest to this board. And they may move forward as early as this summer. We've shared with you previously that ensuring personal services setting clients, that's tattoo parlors, nail places, barbers, hairdressers, personal service setting clients and employees are protected through regulation, can help decrease the spread of infectious diseases like hepatitis B, C, and HIV. And we have been working on a municipal bylaw that would require registration with Ottawa Public Health, as well as enable the public health inspectors to issue fines if people were not meeting those required infection prevention and control guidelines. Ottawa Public Health will now await the provincial regulation with great interest, and we'll reassess whether a local bylaw is needed after we see what comes into effect. And as you may be aware, the province is currently conducting pre-budget consultations. Ottawa Public Health attended the Ottawa consultation, where we highlighted the requirement for additional funding, spending on harm reduction services, early years programming, and meeting the funding gaps and inequity in public health funding across the sector, and of course, to support citywide preparedness for cannabis legalization. With regard to collaborative work across the region, Ottawa Public Health is bringing our neighbouring health units together to collaborate with the Champlain-Lynn. That's Ottawa Public Health, the Renfrew County and District Health Unit, the Eastern Ontario Public Health Unit, and the Leeds, Grenville, and Lanark Public Health Unit, which will jointly focus on youth substance misuse across the region. This will be supported by Lynn funding to the Royal Ottawa Mental Health Centre. This project will include awareness and education training for adults and youth workers to disseminate relevant health information to youth in the community. And the health units will work with a number of partners in the community using similar approaches to those implemented in schools over the last year. So we're excited about this opportunity, and I look forward to collaborating with our other health units and our community partners. Mr. Chair, that concludes my verbal update. Merci beaucoup. I'm happy to answer any questions.
Thank you very much, Dr. Etches. Councillor Fleury.
Yes, merci, Monsieur le Président. Et puis, bienvenue officiellement. On est heureux du rôle que tu prends à Santé publique, Vera. Ma question était au niveau des vaccins contre la grippe. Je pense que dans le passé, on avait discuté de l'approche de santé publique, la responsabilité publique, mais quand on vient à un taux d'efficacité si faible, hein, j'ai lu dans certaines publications qu'on parle de moins de 20%, moi, je me questionne sur la pertinence d'offrir ça au public à plus long terme. Quelles sont notre responsabilité publique en tant que conseil d'administration quand on parle d'une responsabilité où on veut protéger l'ensemble de la collectivité, mais on voit que pour des raisons, évidemment, de différents strains, désolé, j'ai pas de la terminologie en français, qu'on a peut-être manqué le vaccin. Alors, je me questionne sur la responsabilité collective et publique quand on voit que le vaccin, cette année particulièrement, est pas efficace.
All right, so just for others, I think you're asking, Councillor Fleury, about our responsibility to promote the vaccine when individuals may find that the effectiveness for them is low. It's in some years, and for the influenza A strain this year, less than 20% effective. And so overall, what's our messaging? How do we promote the responsibility to be immunized for the collective public? Is that correct?
And more specifically, like someone pays for that vaccine, and it appears to be, obviously we do, I'm not privy to all of the research and the decision around which strains are picked and so on, but when it's such a low percentage, is there still value, and how do we inform the public of that data?
So there is still value. As in my verbal update, we're still recommending vaccination. In fact, greater than 50% effectiveness right now if you have the quadrivalent vaccine against the most commonly circulating strain right now. So that is still better than nothing, right? In terms of if you could prevent a death in an older adult close to you, if you have a young one under 6 months who's not immunized, can't be protected, this is protection that is safe. And so we do promote the vaccine. It's added protection. It's not perfect, but it's added protection, and it's it's expensive to hospitalize, but it's also disruptive to people's lives and potentially very serious. So it's a provincial decision what will be publicly funded, and yet we think for health that it's definitely a message to continue to be immunized to protect those around you, and you may have some benefit from the vaccine yourself.
That's it. Member Fleury? Member Chernishenko? No? Anybody else? Member Kakish?
Thank you, Chair. And I just had a follow-up question on the personal service establishments that you mentioned, because I remember this came up a year or 2 years ago, and we had set direction that we would sort of have a process and bylaw for them. So have we done anything up till now in terms of that enforcement? And I know we've inspected those establishments, but I think we didn't have a database of exactly, we know where they were, but I don't think we've had a systemic place. And so have we been sort of waiting for this provincial legislation to start that, or is this something that we've been proactively and now we'll just adjust based on what the province comes forward with?
Sure. So through you, Mr. Chair, we have always had over close to 1,000 personal service settings on our list that we're aware of. We're concerned there are others we're not aware of, but we have a target to inspect all of those personal service settings each year, and there's good news. We're getting to almost all of them every year, and what we've seen as we enforce is a decrease in the percentage of businesses that are not compliant with the expected infection prevention and control guidelines. So in 2015, there were 20% or so of businesses we inspected that weren't meeting the expectations. In 2017, that was down to only 10% of businesses where they missed something that we would expect to prevent infections, and these are a wide range of expectations. There's progress. We're inspecting. We're not waiting for regulation. The regulation will make sure that we have every last business on our list, and it will give us more tools for those who over time are just not bringing their practices up to expectations.
Anyone else? Seeing none, can we receive Dr. Etch's report? Thank you. Okay, moving on to item number 4, harm reduction and overdose prevention follow-up. We got Andrew Hendricks coming up to do a presentation, and he'll be available for questions and comments after too. Wanted to do the presentation first, then we'll go to the delegation, then we'll come back to the board for questions. Okay, thank you. Okay, Andrew, the floor is yours. Welcome.
So good evening, bonsoir. I'm pleased to be here with Kira Mandrick, who's the supervisor of our harm reduction program, to report back on the evaluation findings of our interim supervised injection service, as well as present our recommendations to move forward. I'm also joined by my colleague from the Champlain Lynn, Cal Martel, who's the Vice President of Integration, and he's here to speak to you this evening about the important work that the Champlain Lynn has been doing with respect to mental health and addictions in our community. As a reminder, in September, the board approved that Ottawa Public Health partner with Sandy Hill Community Health Centre to operate an interim supervised injection service out of our 179 Clarence at Ottawa Public Health. At that time, we received board approval, board direction to bring forward a progress report at the first meeting of 2018, which includes a more permanent solution for enhancing Ottawa Public Health's harm reduction services, including reporting back on results of our evaluation of our first months of service. Since opening on September 26, we've had approximately 3,000 visits to our supervised injection service, which represents an average of about 25 visits per day. We continue to operate 12 hours a day, so from 9 a.m. to 9 p.m., and have clients who visit at all hours of operations. In addition to our supervised injection service, many clients are receiving other health services right at 179 Clarence, such as supportive counseling, wound care, nursing services, such as HIV testing, hepatitis C testing. And on top of that, over 70 referrals were provided to clients, and most of them were for primary care services, mental health and addiction services, housing services, or opioid substitution therapy. And so these are services that we don't provide right at Clarence, but we have partnerships and rely on relationships with other community partners to make those referrals in the community. These additional services that we're providing to the clients are made possible because our staff are building stronger and more therapeutic relationships with clients, which I'll speak to a little bit in the next slide. With respect to overdose response, there were a number of encounters requiring nursing intervention following an injection. Public health nurses provided enhanced monitoring services approximately 20 times. And this monitoring is where a nurse assists the client with their breathing, and it can often prevent an overdose from occurring in the first place. So a nurse will help them with their breathing, sometimes provide oxygen if required, and we've even administered naloxone in a couple situations, and also called 911 to get additional support from our paramedic colleagues. Dr. Etches mentioned in her verbal update that we notified partners last week about some significant overdoses that were taking place at the Shepherds of Good Hope supervised injection service. And I can say that the last week has been busier than normal. Actually, last week we saw the second most visits since we've been open in September, and we have had to respond with naloxone and with a call to paramedics more than we've seen in usual weeks. In addition to the services that we provide at our supervised injection service, we also went out and received feedback from 4 different stakeholders, or 4 different perspectives, and that includes clients, employees, partners, and neighbors. There's a fair amount of detailed findings in the report in front of you in all those 4 perspectives. And so what I'd like to focus on providing you is a high-level overview of some of these findings, and particularly how they feed into the recommendations that we're bringing forward to you this evening. So before we were providing supervised injection services at 179 Clarence, a client accessing our harm reduction services for supplies typically represented a fairly quick encounter, and it may often result in a client getting equipment from us and then going into the neighborhood and finding a place to inject, possibly in our community. Since opening, not only are the harm reduction services being used more frequently, we're also hearing from both clients and employees that there are benefits in having clients stay longer and engage in a more therapeutic conversation with our employees. And that often leads to larger uptake of other services such as mental health and addictions referrals, housing services, and nursing services on site. Clients state that they're receiving non-judgmental and compassionate care in the surveys that we did with clients. And of note, 97% of clients reported being less likely to inject alone or in a public place because of now having access to our supervised injection service. Also, a number of clients have reported that they're only using the supervised injection service that's provided at 179 Clarence compared to other SISs in the community. In terms of feedback from employees, comments were received stating that they'd like to see the development of a sustainable staffing model, which includes formalizing some roles, including the roles of a peer educator or a person with lived experience, as well as introducing a social worker who could help with maintaining those connections in the community, as well as some recommendations on how to improve the services through some of the space that we have at 179 Clarence. We also did some outreach to our neighbors. We went about a 2-block radius from 179 Clarence, and we had teams of employees who went door to door in the surrounding areas to collect opinions from nearby residents. And as you can imagine, residents had diverse opinions regarding the support of Ottawa Public Health Supervised Injection Service, but also on the impact that our service has had in their neighborhood. Of the 59 residents that completed a survey, 51% were supportive of Ottawa Public Health Supervised Injection Service, whereas just under 40% were not supportive. And there's more detailed findings in the appendix that you have in the report. We also conducted a focus group with community partners to better understand how they've been impacted from our service. Those partners included the Lowertown Community Association, Ottawa Police Services, Bylaw Services, Ottawa Paramedic Services, Ottawa Community Housing, and local service providers such as Inner City Health, Sandy Hill Community Health Center. And the majority of partners who participated in the focus group felt that there hasn't been any significant impact in terms of their own organizations. We're going to continue to work with existing partners and community consultative groups. We have a consultative group for our services, harm reduction services, just to make sure that we're responsive to the needs and the feedback that we get from the community. So based on feedback that we receive from clients, residents, community partners, and employees who are working in our supervised injection service, we're proposing that we continue to provide supervised injection services at 179 Clarence on a permanent basis. This will require a submission to the Ministry of Health and Long-Term Care for ongoing funding, as well as a request to make some improvements to the current service area to improve client flow and privacy, as well as allow for a more comprehensive service in the aftercare area after a client has injected. This will further facilitate relationship building that I spoke to between employees and clients, and will maximize coordinated access to services such as supportive housing, social support networks, and mental health and addiction services. The other recommendation speaks to the need to continue our work to prepare for a comprehensive overdose cluster prevention and response across the entire City of Ottawa. So we know that overdoses occur not specifically in one geographical region here in Ottawa, and any area in the city could benefit from an expansion of harm reduction services, including supervised injection services. And last year you heard about some of the work that our Interagency Overdose Prevention and Response Task Force was doing, including the development of an overdose cluster response plan. So what's new in this area is that the province, the Ministry of Health and Long-Term Care, has announced just in January a new process that supports agencies to apply and receive funding to set up an overdose prevention site. And so these are meant to be scalable services to help reduce the growing number of opioid-related overdoses in our community. They're meant to operate 3 to 6 months, so they're scalable, but they're also temporary in nature. And so we'll continue to work with partners on the task force, but also harm reduction partners to support them if they're planning to offer these types of services in our community. So upon your approval, Ottawa Public Health will work with necessary partners, including Health Canada and the Ministry of Health and Long-Term Care, to ensure proper requirements are met to provide these services on an ongoing basis. And we'll continue to evaluate and adapt our services based on community need and in coordination with community partners. That concludes my part of the presentation. Merci pour votre attention.
Thank you very much, Mr. Hendricks. And before we go to board members for question, I want to go to 3 public delegations first. Oh, Mr. Okay. So before we go to the public delegation, can we have a presentation from Mr. Martel? Welcome this evening. Thank you.
Thank you, Mr. Chair, and good evening, members of the board. Last spring, the Champlain Lynn was really pleased to partner with Ottawa Public Health in developing what was at that time our initial joint response to the province, recommending what was required to help the community deal with the increasing pressures around opioid addiction and overuse within the community. Submission was presented as a community partnership organized around the objective of minimizing overdose and deaths due to opioid misuse. In the content, and it was really done in the context of the current crisis sweeping across the country. We currently fund 24 community agencies in addition to the hospital-based care to provide a range of addiction treatment, care, and support. Our goal is to better align these services with changing community needs related to the opioid crisis. While this will require an ongoing commitment, our purpose today is to provide an update on the initial steps we've taken to do so, with a particular focus on the needs of the City of Ottawa and the population. The Ontario Ministry of Health, as part of its 10-year plan for mental health and addictions, has developed a strategy for opioid addiction and prevention. And as the Champlain Lynn has really adopted this framework and align our interventions with the provincial strategy. While our primary focus is in relation to enhancing addiction supports, treatment, and harm reduction, we are currently involved in all three of these domains. So, for instance, we are supporting a full-day workshop later this week for primary care providers hosted at the Ottawa Hospital on the topic of opioids in 2018, tools for primary care providers to stem the epidemic. We're also pleased to be implementing, over the course of this year, a region-wide approach for the treatment of patients with lower back pain. And this will be provided through 20 sites across the region, including in the City of Ottawa. It's being implemented this year and is expected to impact both opioid prescribing practices from a preventive perspective, in addition to achieving better pain management for the patients in this population. However, we are making our biggest investments in addiction supports and harm reduction as a result of the recent provincial investments. These represent a substantial expansion in the scope and the nature of the roles of our various community partners and health service providers. Earlier this year, the Champlain Lynn received just over $1.6 million from the Ministry of Health and Long-Term Care, in part in response to the joint submission we'd put in last spring with Public Health. We made further investments in order to expand services in this area. So $1.7 million was announced earlier this year that went to expanding existing services, but also to deliver new models of service for all populations experiencing substance use problems. Additionally, the Lynn provided ongoing funding to sustain a very successful pilot project, the Alcohol Medical Intervention Clinic at the Royal, to become a new rapid access addictions medical intervention clinic with an expanded scope for patients with opioid addictions to serve all Ottawa Hospital emergency departments, community agencies, and the general public. And as was mentioned earlier in the meeting, we've also used over $600,000 in one-time funding for projects related to prevention, health promotion, early intervention, and system capacity building initiatives to address the opioid crisis. And an element of that is in partnership with the 4 public health units, as Dr. Etches had indicated. This includes a 2-day region-wide opioid training program for addictions and mental health providers across the region. All in all, the Champlain Lynn now invests more than $26.2 million in addiction services across the region. While we have invested across the continuum of addiction services and support for people in our communities, the primary focus has been on rapid access to services for those with life-threatening conditions, like many of those using opioids. And I'll highlight just a couple of examples. We know that many of those using opioids will require opioid replacement therapies like methadone or Suboxone as a first-line treatment. To operationalize this intervention, we've invested in resources such as nurse practitioners, embedded in community addictions agencies that can now prescribe medications. The Ottawa Addictions Access and Referral Service is the central point of access to all addiction services in Ottawa. In addition to coordinating access to these needed services, it allows us to monitor wait lists by service and respond to changing community needs as demand evolves. We have recently funded additional system navigators to connect patients with the services they need, as well as new practitioners within this service that can support clients not only within the referral service, but supporting people in our residential addictions treatment programs as well. All of those investments are active at this point in time. So I'll now speak a little bit more specifically about some of the new investments in the City of Ottawa that total over $2 million at this point in time. So the Sandy Hill Community Health Centre will be expanding their Rapid Access Addictions Medical Clinic to serve hospital emergency departments, community agencies, and the community members directly. This includes a walk-in service, and clients can access opioid agonist treatment through the walk-in now with no waits. Screening and assessment occurs within 24 hours, and time from assessment to treatment is 24 to 48 hours after that. Sand Hill expects to have their rapid access medical clinic fully functioning later this spring. The Ottawa Addictions Access and Referral Service I'd mentioned earlier is also expanding in scope and is partnering with the Rita Wood Addictions and Family Services to offer rapid access opioid treatment to youth and their families in 4 locations across Ottawa. This program is up and running as we speak and is experiencing good uptake from both parents and their children. Clients who call either the Ottawa Addictions Referral Service or Rita Wood are screened and triaged immediately, same day, not yet available on weekends, and can access the nurse practitioner and community withdrawal management workers within 24 to 48 hours. In all of the funding that Lynn has put forward this year, we have made it a condition that the organizations prioritize and triage people with opioid addictions and misuse problems. The Royal Ottawa's Addictions Mental Intervention Clinic I talked about earlier will integrate this new program with their regional opioid intervention service to serve opioid and alcohol-related referrals from area hospital emergency departments. This will also include a walk-in service. This new program started to take patients this week and expects it will take about 6 months to become fully operational in terms of referral pathways with other hospitals across the region. The Ottawa Intercity Health that was mentioned earlier is expanding their targeted emergency diversion program and is adding a managed opioid program. They serve the highly vulnerable homeless and marginally housed populations in the downtown core. This program responds directly to the needs of community members most at risk by providing immediate screening and intake, and clients can get started on Suboxone or methadone usually the same day or next day, either at Ottawa Intercity Health or in coordination with Recovery Ottawa. Both Sandy Hill and Ottawa Intercity Health collaborate with the supervised consumption sites to coordinate their activities and respond to changing and shifting service needs. We have also invested at the Wabano Centre for Aboriginal Health. They will be expanding their addictions and treatment services and implementing pain management resources in conjunction with the primary care for the Indigenous populations they serve. Finally, the LHIN was able to fund new base funding for the Dave Smith Youth Treatment Centre for 2 nurse practitioners that currently work in each of their male and female residential addictions program, integrating primary care into the ongoing and valuable work that they do. We recognize substantial changes are required by our health system to adequately respond and prepare our community for the challenges that lie ahead with respect to the opioid crisis. We're greatly encouraged by the shared commitment that has been demonstrated by our partners in Ottawa Public Health, as well as the health services we fund and work with, to both strengthen and develop new ways to respond to the opioid crisis faced by Ottawa and all of Canada. We're confident that these investments will improve access to needed services at the points of most critical need as they're implemented over the course of this year. But as was mentioned earlier, we know this work is not done and look forward to working together with community members and their families who must face this crisis to ensure we continuously respond and adapt to the challenges ahead. Thank you, Mr. Chair.
Thank you very much, Mr. Martel, and thank you for being here this evening to do the presentation with Mr. Hendricks and with Kira Mandrick also. So moving on to public delegation first. I would prefer we do with public delegations first, if you don't mind, and then we'll come back to, and you're welcome to ask questions of the public delegation here. Okay, so moving on, we have Simone Thibault, Executive Director, and Joanna Binch, Nurse Practitioner from Centertown Community Health Center. And the next delegation after this one is Nanny Cloutier, Executive Director with a peer educator program with Somerset West Community Health Center.
Bonsoir, Monsieur le Président, membres du Conseil. Je m'appelle Simone Thibault, directrice générale du Centre de santé communautaire du Centre-Ville. Je suis accompagnée de Joanna Binch. J'aimerais bien qu'elle travaille avec moi, mais elle travaille au Somerset West Community Health Center. Alors, je vais commencer, puis après ça, Joanna va me suivre. First of all, we appreciate this opportunity to speak to the follow-up report. Actually, quite excited to have read the report. And we'd like to state, first off, we fully agree with all three recommendations made in the report. And we, the community health centers, will continue to work with OPH staff to address drivers of the current overdose crisis with the opioid crisis. So apart from expressing our support, we are here today to reiterate the crucial importance of working with people with lived experience to really effectively respond to this crisis. We agree that now more than ever, and it was named by Cal and Andrew, that we need a range of coordinated and complementary harm reduction approaches that include supervised injection sites. But that's not enough. I think it's great. When I look at the recommendations and the investments have been made to date, it's great news. It's great news for Ottawa. It's great news for people we serve. Unfortunately, there continues to be limited investment in harm reduction beyond the new SISs and the distribution of supplies. We need a longer reach, especially for the most marginalized. If we want to invest in the success of this emergency response, we must consider best practices and invest more in peer-to-peer support. Throughout this address, we would like for each of us to think of a time where we had to deal with a personal problem. And remember how we felt more comfortable addressing the issue first with somebody who had experienced what we were experiencing before we sought professional help. So we need a range of responses, and we must include actively engaging people with lived experience. And I would say that's even more so with those who are most marginalized in our community. It also requires coordinated leadership from all of us, including the LIN, public health, community health centers, mental health and addiction agencies, and our community if we are to make a difference. So I'll now ask Joanna Binch, a nurse practitioner that works at Somerset West Community Health Center, that I'd love to steal, who can best speak to what is happening on the ground in the core of our city.
Thanks, Simone. So I was asked to talk about peers, and then they told me I only had 4 minutes, and so I'll try, because I could speak for hours about something I feel very passionately about. I was asked in 2004 to apply for a job at Somerset West because they were looking to attract homeless people to the area of Somerset West. And I don't know for you, those of you who remember the area of Somerset West, which is Island Park to Bronson, Queensway to the water, but at that time there was open sex trade, there was lots of flags downs with the needle exchange van, and that was the neighborhood. And our beautiful community health center that has a public shower, it's got friendly people, was seeing some homeless people, but it wasn't seeing enough. And so I came along and I had been working with Inner City Health. In the shelter system, I was at one with the homeless. I thought this was going to be easy. And then I met the rooming houses. And so I realized that in other parts of our community, the homeless, on the continuum of homelessness, are housed in rooming houses. And these are like Fort Knox, if any of you have had the opportunity to be in them. And then I realized that the population wasn't a group that had to be outside during the day, that instead they could happily be at home, ignoring those of us in healthcare, because I came at it from this perspective of if you had a toothache, you would see a dentist. And that's not how this population necessarily thinks. And so I was fortunate to meet a lovely peer named Robert Caruso. And I had filled out a special diet for him. We became best friends. And I said to him, I'm having a really hard time accessing a number of the people in this population. And he did something for me. He changed my perspective. He told me, you have to look at this population and you have to be consistent and you have to be respectful, which I thought I had been doing, but you also have to think of it as sales. That in healthcare, it isn't just, we have great methadone or Suboxone, we have great providers, we have a great idea to have a supervised consumption service or injection service. But instead, you need people to be there and you need to have a reputation. And so what Robert did for us at that time was talk about, what is the language that you're using? And I'm sure all of you might know that no matter what the profanities are that somebody says, if you call someone a goof, that is the worst thing you could ever say to someone. And he also said things like, I can access this population because I'm a leader in this field. So why are you bothering to try to struggle? Like, use what's already there, access our community. And I certainly have built into that. And at Somerset West, we have a well-established peer program, and it's continued to grow since Robert. And we've continued to build on these principles. And I think it behooves us to think about what's better for our community in using the peers, but also what they get from it. And it's validating what they're already doing, the expertise that they have, and it's building our community and engaging an area of the population that certainly needs to be valued for the expertise and knowledge that they have. Not to mention their ability to break up an argument faster than I ever will, or to say that, if one of the peers say, oh yeah, she's okay, that's worth 1,000 of me being like, hi, here's my card again. Can't help but notice that you have a giant abscess. And so if you have a peer that says all of those things for you, you're in. And so I think that it's just a reminder that we need to be using our peers to access and advertise what we know are great services, but they do go together. Thanks.
Thank you very much for your presentation. Any questions or comments? Councillor McKenney?
Thank you, Chair. Thank you for coming out this evening and for your presentation. I just want to pick up on what you were saying about the rooming houses. We've been in rooming houses together, and about just around the peer-to-peer, just so that we get a clearer understanding. Is it just me? Is everybody hearing that ringing as I speak? Yeah. So I think it's about a month and a half, 2 months ago, I got a phone call actually from Dr. Etches that a couple of our residents overdosed in a rooming house and had died. I know that it's not the only time this has happened in the last little while, but could you just sort of for us to understand what's the difference? I mean, we have, in Councillor Fleury's ward, we have large shelters and we have, its own set of issues. But in this neighborhood, we're not seeing it on the street. We don't walk down the street and see active users a lot. We see some. My daughter actually and her family live right across the street, so we see some, but it's not in the same way that you might in Lower Town. But it's happening for us in rooming houses, and these folks are alone. So could you just run us through what a peer-to-peer support service would look like, and how that would benefit this community of many, many people who, because we are one of the areas with the highest emergency room visits and overdoses. Just explain to us what that would look like.
Well, thank you, and thank you for your work about rooming houses, who I would argue are some of our most vulnerable and isolated homeless people that aren't necessarily recognized as being homeless. And in a peer program, what we have been fortunate to see is it goes from the very beginning. It goes from access. So again, how many times I've had a peer say, oh, I know somebody in that building who can let us in, or no, you go in the back door, no, you knock on this window. That's how you get there. But it's also a peer that is doing the monitoring, that they're the ones who are going to say, hey, I've had this a number of times, that I've heard through the grapevine that so-and-so needs some help and then you need to see them. And so it's the monitoring piece where they go out. But then there's not enough of us in healthcare to then say, did they go to the hospital? Did they stay at the hospital? Did they follow up on the antibiotics? Did they even have a health card so that they could get their prescription filled? And so it's the access, it's the monitoring, and then it's the follow-up to have the eyes on the ground of the expertise. And then it's also the messaging. I mean, we have the warning out right now that's the beige heroin, and I talk to peers about this. I can put up posters all I want, but it's the peers who are going to spread that message, and they're the ones who come back and say, actually, it's not beige, it's brown, it kind of looks like, chicken bouillon. And so it's that kind of little detail that they're experts of what they do. And why are we not using experts? We use experts in everything else we do. So I think that hopefully speaks to that.
Okay. It does very much. Thank you. And when the recommendation for, maybe this might be a question to staff. Do you want me to wait? Behave?
Yeah.
Okay.
Please.
Okay. I have lots of questions to staff, so I'll follow up. Thank you.
Thank you, Member McKenney. Anybody else? Member Tilley, have a seat.
Sorry.
One more question.
It's more one for Simone. When you mentioned about invest more in the peer-to-peer, how do you see that unfolding? What do you mean by invest? What type of resources would you be asking for, and what type of impacts would you be expecting? How do you see that working?
We need $1 gazillion. No, just kidding. But maybe to also speak to, I'll also add to what Joanna was speaking to in terms of what's going on in our area, and then I'll respond to your question quickly. There's also in Centertown, we're seeing a lot of people who use our rooming houses in Centertown, but they're also using in our subsidized housing units. And it's almost a lot of our affordable single room housing in the Centertown area is being. There's a lot of people with mental health and addiction issues, and so they're there. They may not always be on the street, but they've found spaces, whether in rooming houses or low-income housing. To respond to your question, and something that the follow-up presentation will do, because we are working with Somerset West Community Health Center, which Nani Cloutier will speak to after this presentation. We made a submission to the LIN to get a pilot of increasing the peer-to-peer support with Carlington Community Health Center, Centertown Community Health Center, and Somerset West, because we felt there's something great happening at Somerset West in terms of the peer-to-peer support. It's also a partnership with Ottawa Public Health, where let's work with what's working and let's expand that and see what it would look like at Centertown, what would it look like in a Carlington neighborhood, and sort of define. And it's also an opportunity to hire peers to orient them to working within the community health centers and see where can we go with that and sort of expand. So we're looking at we have a small amount of investments that was made from the LIN. How much would be required overall? My take would be that I don't know how much that amount would be, but I would say if we continue to spend in emergency, if we continue to spend on clinical work and don't spend on increasing our reach to those most in need who are quite marginalized, who are dying, we missed the boat. And I think the LIN and Public Health said it in the first part of the presentation that we need multiple factors, multiple avenues to deal with this crisis. I'm not seeing enough investment in harm reduction to engage the peers, the people who use drugs, to be part of the solution. They've got amazing tricks and amazing ways of connecting with people who are most marginalized in our community. If we don't get that right, we're really missing the boat. So I can't give you, I wish I could give you a number, but I think I'll be, how would you say, cost effective in that I think we need to demonstrate what it could look like, and we need to work with our partners and come up with a number and based on the needs that we're seeing in the community. But thanks for the question.
Thank you.
Anybody else? If not, thank you very much, Madame Thibault and Ms. Bench, for your presentation. Now, I would like to invite up Nanny Cloutier, Executive Director as a peer educator with Somerset West Community Health Centre. Welcome, Naini, and if you can introduce your two partners that have you brought with you, you have 5 minutes to present to the board. Thank you very much.
So with me, I have Karen Whitehead and Mika Conboy, who are peers with us for many years. So first, I'd like to thank the Board of Health for your support for a supervised injection site at Somerset West Community Health Centre, which we are in the process of setting up. And in addition, as has already been talked about, building on our over 7 years of experience in a peer-supported harm reduction program, we have just started a 3-month initiative that Simone talked to with Carlington, Centretown Community Health Centers, and the OPH, Ottawa Public Health. And the idea behind this is to fill the gap in addressing the overdose crisis currently. It's a short-term funding that we have received from the LIN. And through this program, what we are doing is hiring and training peer harm reduction workers with lived experience. And these workers are going to be providing safe supplies, going to be outreaching, and will be referring people to services. And as was just talked about from Joanna, the intention is reaching out to those who are hard to reach, people we do not see in our centers, and those who are really isolated, as well as to establish some kind of credibility. We believe that in order to reach a community, any community, including that of users, the best way is to engage the community, as was shown so excellently through the OPO tents that were set up in the city of Ottawa, where the peers played such a big role. And the hope of this project is to demonstrate the value of a peer harm reduction approach, and to show that the peers are able to not only provide low barrier services and to improve access to supplies and safer use, but they're also critical in creating a sense of belonging to the community, not only for the users, but also for the peers. By reducing stigma, by greater connections within the community, and by also building their own capacity. And as Joanna said, there's an expertise in the community, and people are able to support each other. Services can be there for only so long. During the after hours, it is the community that supports itself and each other. And at this point, I'm going to ask our peers to speak, who have extensive experience and expertise. So Mika Conboy first.
Hi everybody, my name's Mika, and I was...
Could you turn on the white button in front of you there, on the mic?
The button.
Thank you.
Can you hear me now? Hi, my name is Mika. I've been here before. I think last time I was here, I told you I used to be a hookah, and I don't know if you remember that, but it was about a year and a half ago I was here, and it was kind of funny. Anyhow, I'm here on another note talking about peer workers at Somerset West. I've been going to Somerset West for many years, and I've seen a lot of changes happening, baby steps happening, and I've seen peers that they used to smash car windows to get change out of someone's car. And now they're not doing that anymore. They're coming to Somerset West, and they're working. They're actually applying themselves differently. They're taking care of their personal hygiene. They're combing their hair. They're brushing their teeth. They're wearing clean clothes. They're not doing that criminal activity so much anymore because they're feeling better about themselves. They have built trust with the workers at Somerset West, with the nurses, with the doctors, with the nurse practitioners. By word of mouth from other peers, they hear that you can come here, you'll be trusted. They won't say anything about you. They won't judge you. They help end isolation. Like, there's a lot of people that won't come into services because they're afraid of having someone call Children's Aid, or they're afraid of people saying, they're going to talk about you, about your addiction. They're going to call the police, and those things don't happen. Because of peer work, word of mouth happens, and they're able to sort of slowly gain trust with somebody and then start taking care of their health issues. So I think from the 20 years plus that I've been going there, I've seen a lot of change, and I think it's really good. So I think peers need to be more included. They help solve a lot of problems, and it's becoming more and more apparent that they do have knowledge and they do have lived experience, and I think that's really important.
Thank you very much for your presentation. Your time is up, but I'll provide another 30 seconds to the next presenter if you want to use that.
Hello, my name's Karen. I've been a long-time client at Somerset West as well. I've been going there for 35 years. I have mental health and substance abuse issues. For me, I think having these put in place to be able to learn how to use harm reduction, to be able to stop the stigma in the community. I live in Lower Town now, so I'm coordinator for Dual. I've been able to empower the peers to be able to see that they have a voice in the community, to be able to come out and not be so isolated, to come to the drop and feel like they're safe in their space.
Board direction to move forward with a permanent OPH-led application. At that time, we still weren't sure when Sandy Hill was going to be up and running, and the way that the Health Canada approval was written was in the event that Sandy Hill gets up and running, we would need to discontinue our services. So we have moved forward with submitting an application to Health Canada to switch the application from Sandy Hill to Ottawa Public Health. We've been working with Health Canada to follow the processes. We've submitted that application, and we're still waiting for final approval to do that. So what would take place now, pending approval from the board, is we would want to provide services on a permanent basis. So any changes we would make going forward would be an amendment to that Health Canada application.
Okay. And in terms of, as you know, I visited, the space is quite limited. Mm-hmm. You're asking for additional, sorry, I'll use the right word, because to add the consumption site components to the existing services. Can you speak to, obviously I think the need is pretty visible, but in terms of the actual space in the facility, how is that going to adapt, and how do we see the proximity to the trailer as one of the factors? Maybe you could speak to both of those.
Yeah, so I can speak to the physical changes or the changes to the service offering. So back in September when we got up and running, we were really wanting to get up and running as soon as possible to respond to the community need. Now that we have experience offering the services, we've got about 4 months of experience. We are wanting to make some changes to the service area. So what we heard from clients and from employees was that we need a little bit more space to provide the services, including a little bit more space, especially for aftercare supports. So after the injection takes place, and that's where we talk about introducing the role of a social worker to facilitate those referrals in the community. So we'd be looking at, I'd say, a small expansion of the space, but not I wouldn't describe it as a significant one. So probably adding another injection booth, but really the additions that we're wanting to make is to improve the services in terms of aftercare supports.
Okay. And maybe you could speak to the actual, because when Inner City Health came and talked about the trailer was meant, in my understanding, for clients of Inner City Health. Obviously, we adapt, and obviously the needs are much greater than that. How do we see, both efforts being complementary to one another? I know that some of the speakers were saying, hey, the proximity, how do we know the services are overall not competing? So I'd love to hear from you on that.
Yeah, I can start by speaking about how we work very closely with Shepherds of Good Hope. I think between Kira and myself, we probably speak to them daily in terms of just what they're experiencing and what we're experiencing. So it's a very close partnership and a productive one. In terms of the service needs, I mean, I give the same answer that Board Member Tilley gave in terms of service needs. If you just look at the last week, both the trailer and our SIS saw the largest volume of visits that we've seen since we've been opening. So there's definitely a need in the community. We know that drug use is concentrated in the downtown core. We know that based on emergency room visits when we look at postal codes. We know that based on some of the use of our existing harm reduction services. And so we feel that there is a need to have multiple venues where people can access these types of services within close enough proximity to one another. We also heard from clients that access our services that some clients only use our service. They don't necessarily use the trailer just because it's there. And we've heard some similar stories from clients who are accessing the trailer as well. So it really becomes a preference. You build that relation. I talked about building that relationship with clients, and that provides continuity of care where you can build that relationship with somebody over time and then possibly work with them if they need other services. So, I feel that there is enough demand in the community to have multiple services going on at once.
Certainly my community overall, I know statistically, I think you're speaking at 51% of neighbors are comfortable and in support of the idea. I think generally people, even though they might have different political leniencies or positions, feel that it's removed the drug consumption from the neighborhood. We have seen drug activity, which is not necessarily a public health matter, but more a policing one. I recognize and I'm supportive of the team and the effort. I would like Ottawa Public Health, though, to go a step further, which is now we're offering services in a given neighborhood. I know that other services will expand to Centertown, but I think it's time to have a discussion on the mobile van. And I think that there's users that are found outside of the more traditionally dense areas that are not accessing services now. And that's where I think, fully supportive of what you're bringing forward in terms of 179 Clarence, but I think, going forward, we do need to look at offering additional services where folks live, which again removes, and I would say this to any community, it removes the drug use in the community, and from a treatment point of view, there's an access into services. And I'll wrap up on this. Maybe one of the key things in your slide was around the 25% people have asked for additional services. I think from a board perspective, it'll be important to have maybe a report specifically to that, in 6 months or a year from now, to say people are looking at this realm of services and here's our successes or here's our failure relating to that, because we have no clear understanding of Are people, okay, they're asking for services, are they accessing it, are they happy with the services? We're not perfect as an overall partner in the community, so we want to make sure that as a board we also have that responsibility of understanding when people are asking for services, that it be treatment or others, that the door's open in that regard. So maybe I'll stop here because I've asked a lot of comments and questions to Andrew, but I'd love to get back on and speak to Mr. Martel just after I have a few questions for the LHIN specifically.
Okay, I'll give you that opportunity after the rest of the board has had an opportunity. Member Lakin, please.
Thank you, Mr. Chair. I think my question is to Andrew, but I want to first acknowledge Mr. Martel being here. Thank you for taking the time to be with us this evening. In my view, you sitting here with us represents a number of things, but in particular, the concept of integration, the concept that what we're trying to do here is integrated across the community with services and programs. And with that in mind, I guess it's a question which is to ask, as we think about this version of the service becoming permanent, and in what way can this point of entry be more of a one-stop shop, so that folks that have taken the time to enter through the doors can not actually, to what extent is it possible to do some of what we do in-house versus refer it out in order to enhance the effectiveness of what we're trying to do?
Yep. So thank you for your question. It is something that we've been thinking about for some time, and I could say that we're still very early on our journey in terms of providing supervised injection services, and that includes building some of those relationships that I've talked about. In recent months, we've considered whether we want to add opioid substitute therapy as an example. We don't currently provide those services, and not many health units across Ontario do. We know our Toronto Public Health colleagues do, for example. And so wanting to speak to them and learn from them about their experience of doing that, and also meeting the community needs. So we know that I think it's around 15% of clients that responded to our survey said that they were already accessing opioid substitute therapy through other venues. So that's just one example of something that we have been thinking about recently. We've done a lot of work just in terms of tracking referrals, in terms of even the success of our referrals. And so what happens with clients now when they come back on consecutive days is we can follow up with them and we can work with them more on a case management type basis to see if that referral was successful, if it really if they ended up getting the services that they were intended to get. So we're really hoping that the introduction of formalizing a social worker role will help with those types of things, and I think that'll kind of springboard some of those discussions in terms of providing more wraparound services to the clients.
A quick follow, if I could. I wasn't sure how to read the comment in the report that those surveyed, partners that were surveyed reported no impact, and I didn't quite know how to read that. Should I be reading it that there was no negative impact?
Well, I think
the reference was to the presence of the SIS in the community, that there was no impact as reported by police and other partners.
Right. So the focus group that we had with community partners was specific around Ottawa Public Health's supervised injection service, and they were feeling that with us being service providers in the community since September, that they weren't feeling any impact on their organizations. What did come up in discussions with neighbors, but also with partners, was that, it's a little bit difficult to associate causality, let's say, because there was a lot of activity with respect to overdose prevention Ottawa being up and running over the summer months, as well as the introduction of the supervised injection service at the trailer. And so there was, caution in terms of saying that the impact was because of our service versus another service. But partners did say that they didn't feel any significant impact on their organizations.
Thank you very much, Member Lakin. Member McKen.
Thank you, Chair. Thank you to staff. I was just sitting here thinking how far we've come in, not very far, year and a half, where supervised injection services seem almost quaint. I think that, over the summer with the overdose prevention and the work that was done there and what we're hearing about what's happening in rooming houses in other parts of the city, in particular in the Centertown, Somerset West area, I am really heartened to see that, there is movement. We are, unfortunately, it's taking many deaths and overdoses to get there. But we are at a place here today where we can talk about the whole range of services that are needed and beyond supervised consumption services, that include that cluster of prevention services, that includes peer-to-peer support, and how we're going to move forward. I mean, we just heard tonight that, we had a spike in severe overdoses that are consistent with carfentanyl. And I think that, for anybody who doesn't know what that is, it's what they use, for elephants. So that's terrifying that that's entering the market in the city. I just wondered, two questions. One, on the recommendation, the third recommendation, that we approve that you work with partners for comprehensive overdose cluster prevention and response across the city. Does that include overdose prevention as we need it to scale up and down? Does that include peer-to-peer work that we heard tonight is so critical that in those, I guess, almost invisible spaces where we don't see them. They're not out in the street. They're kind of the hidden homeless, if you will. And is that what that includes? And if it does, where do we see that funding coming from?
So I would say that it's included in that cluster response plan in probably a couple of places. So one is around the announcement from the Ministry of Health around overdose prevention sites, and that now becomes a formalized process and a venue in which we can have people with lived experience playing more of a role, or more of a formalized role when it comes to overdose prevention services. Also, a big part of the focus in the overdose prevention and response cluster plan is around naloxone distribution, and getting naloxone out into the community to anybody who needs it or anybody who's who has loved ones who are at risk of overdose. And so we have experience with our peer overdose prevention program, our POP program, that is a peer-led program that's been running since 2012, sorry. So, and so that's a peer-based model. It's a model where people with lived experience are trained on naloxone, and they are able to get out into the community to prevent those overdoses from taking place, and those are places where we can't always be, right? So that's where that would also be included. So
okay, so just so that I'm really clear, so the Ministry of Health long-term care funding that was just announced, which is fantastic, that could be applied to from a health center for the peer-to-peer programs that we're talking about this evening.
So the funding, Vera looks like she wants to say something, but okay. So there is a funding formula for overdose prevention sites. So any organization or agency or harm reduction partner that wants to apply as an overdose prevention site, the ministry has outlined the application process, but also the funding formula that goes with that, and it's based on the type of services that you provide at an overdose prevention site, the hours that you're operating, the number of months that you're operating. So there's a funding formula for that.
I'm just wondering if Somerset West and Centretown Community Health Center are looking for funding once the pilot runs out. Where could that funding come from for a peer-to-peer program?
Yeah, so I think right now that funding is a partnership with the LIN, right? So it's an application that's in with the LIN, and so that's the funder right now is the Champlain LIN. So maybe Cal wants to speak to it.
Well, actually, that leads me to my question to Cal. On the 1.7 million. How much of that is going to harm reduction and peer-to-peer response?
The majority would be going to the rapid access treatment and harm reduction programs. The peer support programs that were mentioned earlier, we were pleased to be able to pilot and test those. We have good experience with peer support programs in the mental health and addictions generally, but I haven't tried those yet within the opioid community.
So stay tuned. Is that what you're... When the pilot runs out, we can come back and ask for further funding?
So typically the process would be you pilot, evaluate, and then consider in relation to other priorities, absolutely.
Okay, thank you. Just one other question, Mr. Martel, in terms of treatment. I guess it's a year and a bit ago, we had someone from the LIN came in and talked about the wait times for treatment. And at that time, and things changed very rapidly in this context and in this environment, but at that time, there wasn't a true bottleneck in terms of getting into treatment. I think the average wait time was 10 to 14 days, and that's when we were considering our approval, like in process for supervised injection. Is that still the case? Do you see a bottleneck in treatment? Like, what are the numbers for people entering treatment?
So similar to some of the comments you've heard earlier, there's, with the 24 providers that we fund, there is absolute variation in terms of access to treatment that could range from one day to several months along that way, which is why we have really prioritized models of service that can ensure rapid access. So as a result of these investments, 5 of the providers that I've profiled here today can provide same or next day service in terms of access to treatment services.
So there was a bottleneck in treatment in your assessment, or the LIN's assessment, the bottleneck was treatment over other say harm reduction, or I just wonder why, just as I looked at the list, I just noted that it was mostly going to addictions treatment. I'm not arguing that. I'm just wondering what has changed in the last year and a half since the LIN came to us with essentially a table. I don't have it with me today, unfortunately, but I do have it. Just that showed, and you're right, there was a range, but it wasn't necessarily where the bottleneck was.
So we receive that same report on a monthly basis because we fund the Ottawa Addictions Assessment and Referral Service, who monitors those wait lists, as I'd mentioned earlier. Okay. And again, depending on the service, then and now, you can experience delays or wait times to get to a particular service that you're looking for. Certainly with the investments we've made and the initiative from various partners, the initial rapid response is much more quick than it has been. But there does need to be, as we talked about, a full continuum of service offerings that reflect what people are ready and need.
So the last person that came up to speak, I think he's left, but unfortunate, because I think you're answering his question, and there is an investment in treatment.
Yes.
Yes. Thank you.
Thank you, Member McKenney. Member Taylor, please.
Thanks very much, Mr. Chair. Andrew, I guess one of the questions, and I guess this relates a little bit to Mr. Annabelle's flamboyant presentation, when he talked about the proximity of one site to the other. One of the things that's become clear, I guess, to me in seeing how these sites were deployed and how they developed, and specifically in talking to some of our partners who operate, you know, the inner city folks who operate the trailer at the Sheps, and, you know, OPH staff who run our site, they attract a different kind of user, a different kind of client across each one of these. And in fact, I've spoken to people around the Sheps who say, I would never go to the Clarence site, but I would come here. And I imagine there must be the reverse as well. So I guess I would ask, but also encourage, if it isn't happening, I know there must be some kind of, as SIS sites become more commonplace, or SCS sites become more commonplace in our community, there must be some kind of discussion that happens on a regular basis between the sites. And if there isn't, I would encourage that there should be, not just the one manager gets together with the other manager once a month to chit chat, but something a little more formalized. I don't know if that's taking place, so that would be one question. And if it's not, I'd suggest it probably should, especially as these sites are starting to emerge. The second would be actually that while you may all strive for certain clinical goals and outcomes that are identical to each other, that you actually look for ways to be different from each other, rather than, being the same. And I think we heard, from some of the peers who were here earlier, they talked, directly and indirectly about the feeling of the experience walking in. And I can imagine that if you walked in and you were looking for something you were looking for a personal connection, and it was a more clinical feel, as I think our site probably is, it might not be what you're looking for. It might not put you at ease. So I guess the question is, are we communicating with the other sites now? Is there any kind of formal plan for communication? And can you talk a little bit about, do you see yourselves growing similar or different, or how would you kind of capitalize on the different user?
Before you gentlemen go ahead and answer that question, I do have a motion that I ask Madame Pinel to move. Please.
Be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 8(1)(c) of the procedural bylaw.
Is that carried? Carried. Thank you. Go ahead and respond to Member Taylor's question.
Yep. So I'll address your first question. Yes, those formal meetings are taking place, and they've been taking place even before the summer, when there was any supervised injection service in Ottawa. We meet regularly, so almost monthly, but not always every month, but probably every six weeks or so. We've been meeting with some of the community health centers that are in the room with us. Cal's been to those meetings. Overdose Prevention Ottawa we extended the invitation once they became service partners as well. And Ottawa Police Services was also part of those types of meetings. And so in the early days, we were meeting to just talk about how, really in planning mode, in terms of overdose response, overdose prevention, and then in more recent months, we've been talking about how we can have consistent approaches where possible. So sharing evaluation plans. I presented the evaluation plan. There's interest from other service providers in our evaluation plan and the methodology that we've used. Even talking, using the same language. What's an overdose? It sounds like an easy thing to talk about, but just the way that we report out on number of visits, number of encounters, number of overdoses, those are other discussions that we've been having across partnerships. So we're going to, what I've heard from partners is they find those meetings useful. We've been talking recently about some of the peer work that Centertown and Somerset West have talked about as well. So So we're going to continue to host those meetings. I tend to chair those meetings, and we'll continue to meet on an ongoing basis. So in terms of your second question, you know, I agree that some services, you know, need to look a little bit different, need to feel a little bit different. What I would answer now is that we're still very much in the early days, just as a community, in terms of providing these services, and so it's hard to say what the you know, what things will look like, you know, in a couple of years' time. We know that services tend to change over time. You know, in the presentation that I spoke to, you know, I mean it when I say that we're going to continue to be responsive to client needs and community needs. We don't even know what, you know, we imagine we know what it's going to look like when there's other service providers in the community, but it may shift the needs. It may shift what we need to offer as a service, and it may shift what other service providers are doing as well. So, I think that the important part is listening to clients and listening to community in terms of ensuring that we're meeting their needs, and being adaptive to what the community needs. So it's hard to say exactly what, you know, I'm not sure if that addresses your question, but we're a little bit different. What we hear from clients is we're a little bit more clinical. I think you used the word a little bit more clinical. That's what we hear from clients in terms of how we compare to the trailer. We're smaller in terms of size, so you know, there's different feels to the different service delivery.
Yeah, thank you. I think that answers the question. I guess, you know, to the second point, I would encourage that as you continue to have those meetings and you look at what your emerging kind of client needs are as individual providers and community needs are collectively, that you know, you encourage the partners around the table. Everybody should own a need. Sometimes those needs will be incongruent. You'll say, well, we have clients that want us to be more clinical. We also have clients who want us to be less clinical look and feel. So if someone owns the less clinical look and feel and someone owns the more, then we'll ensure that the entire community has a place to go and there's good referral between the different SCS, SISs. Thank you.
Thank you.
Thank you very much. Member Tilley, please.
Just, this might be more for Kira as well too, Andrew, but just wondering, so you're currently seeing 25 visits per day, and we have 2 bays, and I'm wondering, by looking at the numbers I saw in the report, I know there's a rush period at the beginning, it seems. In terms of capacity, what would you estimate would be the capacity for that 12-hour period if the visits should increase?
Sorry, for the capacity if we increase to 3?
Yeah, about how many people do you think you estimate we could take in a day? I hear of the numbers happening at the trailer, and I'm just wondering, are we 2 bays is enough for the future as we look at setting up at 179 clearance? It sounds like we probably have room to take in more people.
Yeah, so I think Andrew spoke to it a little bit earlier, that this last week we definitely have seen an increase. So over the last few days, we've actually pretty much seen our maximum capacity
of clients.
So
now.
we I would want to say over the last 4 days or so, we have noticed an increase. And in speaking with Wendy, they're seeing the same thing. So they're seeing about as many folks as they can in a day, and we are referring between the 2 sites when that does happen. So by adding a third booth, it will allow for us to meet that change.
Sorry, so with 25 people, that's our capacity now then?
No, sorry, when I'm saying the last few visits, we've been upwards of 50 people in I think 49 was our highest this past week. So we're seeing that. So being open for 12 hours, that's about the maximum, getting people through safely. We're wanting people to stay, you know, after for the post-monitoring. So some of the changes to the space also will help with that. Currently, when people are using the service, we have them staying in the injection room for all of the post-injection monitoring because we don't have another space for them to go. By adding in an aftercare area, we'll be able to move people through to that space to stay after for that monitoring as well.
And what I would add to Kira's response is that with the way that that we're planning to lay out the space, I anticipate that it would be a little bit more efficient in terms of the way that the clients would flow through the area. Right now, it's pretty much an open area, and we want to have an open area, but it's just the way that the clients would flow through from intake into the injection area and into the aftercare area, which probably results in a more efficient operation.
Thank you. Member Kakish.
Thank you, Chair. I just had a couple of questions to staff with regards to the survey and the stats that came back, and not to rain on your parade, but that 40%, 37% of residents that were opposed to it, and if you can talk a bit about that and on a go-forward basis how you'll be addressing some of those concerns, because we know having the community on board with an initiative like this is a big deal to its success. And the other point, and I know you mentioned that there's no relation, but there is a 55% of jump in crime. So same line of questioning, what are you going to be doing on a go-forward basis to collaborate with police, and what more do we know with that? I know you said they're not, we don't have correlations too early from 1 year to suggest any kind of pattern, but what's the explanation we have from OPS, and how on those 2 points on a go-forward basis are you going to be improving those things?
Yeah, so in terms of the first questions around neighbors, I think the stat you were referring to was around support from surrounding neighbors. One of the things that we've been doing for many, many years, just in terms of our harm reduction services, is we have a consultative group that we use to get feedback and input into our services. And so that would be the venue in which we would continue to get feedback from the community. So currently we have a variety of community associations that take part in that, Lower Town Community Association being one of them. We also have the people with lived experience on that committee, on that consultative group. We have Ottawa Police Services on that group as well. And so they have been involved. They provided feedback, on things like our peer overdose prevention program. But we've included them in pretty much every step of the way in terms of even before we started offering supervised injection services. So that would be the venue and the mechanism in which we would continue to engage with them in terms of the not feeling supportive or feeling like there's any impact on their community. So we'd work through that network and through that consultative group to get feedback.
Sorry, and not to interrupt you, Andrew, but so in terms of, is there a pattern of concerns when they oppose it from those residents that oppose it? Is there a common message or theme? Is it philosophical? Is it political? Or is there something specific that hasn't been addressed that we can address?
Yep, so just a sec, I'll pull that up because I do have that somewhere here. So some of the, just a sec, I have a summary here. I'm looking over to Lise, who helped with the evaluation plan, so just a sec. This one here? Yeah, just the comment.
Their concerns was mostly
yeah.
crime.
Yep, so some of the concerns that Lisa's, I'll ask Lise to confirm. So it's part of the contextual factor that I talked about earlier with the introduction of other services in the community at the same time, so Overdose Prevention Ottawa and the trailer. What we heard from the community was concerns around crime and safety in the neighborhood. What we heard from people was some dissatisfaction with city officials in terms of a lack of response to some of the activity that was taking place in the community. We heard, a lot based on behaviors that people were feeling what was happening in the community as a result of some of the supervised injection services. So that's at a high level what some of the concerns were from neighbors in the surrounding area. Yeah, anything to add? That summary. Yeah.
On the police side of things?
Yep, so I'll start by saying that our relationship with Ottawa Police Services right from day one has been excellent. We involved them in the beginning, even before we were set up, in terms of the layout and how we would provide the services and how we would partner with them. We have to have a formal partnership with them in the event that a client leaves drugs, which is an unknown substance. So we have formal mechanisms to connect with them, and they provided input into the design and the delivery of the services. And so it's been really a strong partnership, and we would continue to do that. More formally, they sit on that consultative group that I spoke about. They also attend the regular meetings with community partners in terms of supervised injection services. So we have, typically it's a Deputy Chief Jill Skinner who's been attending those meetings. And then more on the front lines, Kira connects frequently with some of the frontline officers to if there's anything in particular that needs to be addressed. One of the other things that we're working on with Ottawa Police Services is rotating them in to the supervised injection service so that they can see what it's like in the service. We would be doing that outside of operating hours, but we did that many years ago with our mobile van, so that with the site van that operates on evenings, where we rotated them into the site van so that they can see the type of services that we're providing, and we're trying to set that up with Ottawa Police Services as well.
So other than not being correlational, do we have any kind of analysis or insights on that 55% and what's going on there?
Yeah, so when we met with the data analytics people from Ottawa Police Services, they really cautioned us in terms of associating anything specific to one specific location, again because of the number of services that were up and running over the summer months. What they really felt needed to be done was to collect more data over a longer period of time, so that they could really have more of a sample to know if it was because of one specific service or not.
Dr. Edge, did you want to add something?
Yeah, so thank you for your questions. I think what you could look for from us is ongoing measurement of these aspects, these perspectives. So this is one point in time we want to see as we continue community conversations and we go door to door again to neighbors, are we hearing more support? Have we addressed some of those concerns? As we work with the police over time, we want to continue to monitor what's happening with crime in the neighborhood. So I think this is an initial assessment, and these are figures that are part of our ongoing evaluation. So you'll be able to come back to have more of an answer over time.
Okay. Do we have any idea about the future of OPO in terms of if they're intending to continue to do the work that they're doing in terms of pop-up sites and locations? And
I do not.
Okay.
No, I don't have any insight in terms
so
of.
So have you had any discussions with them in the past weeks or months, or?
No, other than the meetings that I referred to in terms of where we get together as service providers, but they hadn't, at that meeting, that they never specifically mentioned what their intentions are long term.
Okay. Yeah. And just finally, that $75,000 that we got for this was from the province, correct? Or?
Yes, we're looking for that funding still to come through, actually. So again, we've spoken with the ministry. I've spoken with the Assistant Deputy Minister. She says our applications are being viewed favorably. We just don't actually have that money yet, but it's from the province.
Okay, and so are we asking for a year or months, or how does that work when we ask for that funding from the ministry?
So that was a funding request that was for the end of last year and would help us with the startup of this year. With your approval for the plan going forward, then we would be making a new funding request that would be for 2018. And it would be base funding, so it would be ongoing request to the budget that comes in as base.
And so
funding.
is the 75 typical about what it would cost, or was that because there were some startup costs and other preliminary costs?
Actually, this may be a good point for me to thank the team for the incredibly fast startup job that they did do. There were very little capital costs in the startup. They acted quickly to make the space workable, and then the $75,000 per month was actually mostly salary. And so that's close to the ongoing cost we expect. And that is in line with other sites like Toronto Public Health, Inner City Health on a, if you compare the scale, it's similar to, again, the scale would be for Sandy Hill Community Health Center, so we're in line.
Okay, thank you. Thanks, Andrew, to you and your team as well.
Thank you very much. Final wrap-up questioning from Member Fleury.
Yes, thank you. Again, my questions only relate to the LHIN. I've seen organizations, mainly our resource centers, kind of losing track of being coordinated. And I wonder, I'll specify what I mean by that. Each individual board needs to approve and submit individually their request to Health Canada. Is there a role for the LHIN to help our, I guess we're 15 health and resource centers in Ottawa, better coordinate that approach? Is there a way that we could support them in that regards?
So if you're talking about the approach or coordinating approach to supervised injection sites, that is not in the mandate of the LHINs at this point in time. It rests with the Ministry of Health and Long-Term Care in Toronto. On any instance where there is an issue or concern around local needs, we do provide advice in those processes.
Okay. Then it applies as a general comment that, I do see a gap in my mind that every board, and what that means is that it emphasizes a lot of pressure into one given neighborhood, while if we think it's an important service or important pillar, it should apply across the health system. Imagine if we only offered flu shots in one clinic, how people would feel towards that. So certainly that's how I feel around the services, is if it's an important one, well, why isn't it important for every health center? So that's my perspective into it. In relation to the follow-up to Councillor McKinney's point, and certainly thank you for those responses, I struggle as an elected member, as a community leader, and as a Board of Health director to, on a weekly, monthly, yearly basis, understand where those backlogs are. So I wonder if there's an opportunity for the LHIN, or if that data is available, to have a bit of a dashboard and see, if you're a youth struggling with addictions today, if you're female, male, age groups, to start seeing a bit more of the profile, because we speak generally and we hear from communities who are struggling with overdose and deaths and use, but we certainly have, in my mind, no true understanding of where those pressure points are above what we hear in our community. So maybe you can enlighten my mind around how we best deal with that issue.
So as was mentioned before, we do have a single point of access for addiction services within the city. It is the Ottawa Addiction Assessment Referral Centre, and they do provide and monitor wait times and referrals to all of the services that we have talked about here today. If your suggestion is, and I think it's a good one, is there a way to inform the people who are doing the system navigation to these points of care when needed? Certainly we'll take that under advisement, have a discussion with our team on how to do that. Having said that, in the short term, the areas we've invested in terms of rapid access have responded to a lot of the critical points we've heard from the community over the past year. So for instance, for youth and parents who were struggling, particularly out in some of the suburban areas. So now that Rideau Wood, in partnership with Montfort Renaissance, has those 4 points of access, they're able to respond both in terms of counseling, but also nurse practitioner and withdrawal management within 1 to 3 days, which is a rapid transformation from the experiences we've heard for those who are waiting for designated beds. And on that point, I think there's been a number of discussions around the need for more beds. We currently fund 400 treatment and stabilization beds across the region, which is not an insignificant amount, but it's not necessarily an avenue that you can consider for rapid response. There's infrastructure and other issues addressed in building that capacity, and so we've erred in the short term in building sort of community withdrawal and treatment options within the resource centres, and but some of the other hospitals we've been talking about as well.
Thank you.
Okay.
Member Lakin?
Thank you. Just a very quick comment on the heels of Member Fleury's comment that as a point of entry, the SIS as being a point of entry for users to health promotion and harm reduction, to ensure that what we do at OPH is integrated with the provision of mental health and addiction services. And any user will tell you how disconnected services can be. As we move forward and look to make a more permanent solution, which might include other professionals, that would include methodologies to connect with that single point of entry and the breadth of services, given how important it is for users. So.
Thank you very much, Member Lakin. And first of all, before we go to the report itself, I just want to thank Andrew and his team for this report that he's put forward, plus coming to answer all the questions. And also thank you to Mr. Martel for joining us this evening to respond to some of the queries from the board members. Having said that, the board report recommends that 1, receive for information the evaluation of the interim supervised injection services as summarized in this report and detailed in document 1. Number 2, approve that a permanent supervised consumption site be established at 179 Clarence Street to be operated by OPH, and that Ottawa Public Health submit a request to the Ministry of Health and Long-Term Care for ongoing base and one-time capital funding, 100%, in order to provide the permanent SCS as outlined in this report. And number 3, approve that Ottawa Public Health work with partners to prepare for a comprehensive overdose cluster prevention and response across the City of Ottawa as described in this report. Is that received? Carried? No, it says just to receive it, information.
2 and 3 are approved.
Yeah, okay, sorry. 2 and 3 are approved, so carried on those 2 items? Thank you. And once again, just was a great discussion this evening. We took a little over 2 hours to go over this one item, okay, just as a comment going forward for the rest of the evening. Item number 5, preparing for legalization of non-medical cannabis. And we got Jillian Conley and her team coming up to present. Jillian, when you start, you want to introduce the rest of the team members on your team, and then we've got overnight to present.
Thank you, and good evening, Chair and members of the board. I have with me here today Jessica Brett. She's a public health nurse with our substance use team. So this evening I'm going to provide an overview of OPH's plans to prepare for the legalization of cannabis, which is before you. I'm also going to provide an overview of OPH's recommendations to Health Canada's consultation on the regulations to assist in the implementation of the Federal Cannabis Act, as well as provide an overview of OPH's recommendations to the provincial government's consultation on retail sales. OPH's recommendations on these consultations are before you this evening for your adoption. First, as a starting point, just a bit of an overview of the current status of the provincial and federal legislation. In April 2017, the federal government introduced the Cannabis Act. This past December, the Provincial Cannabis Act was enacted. And in January, this past January, there's been provincial and federal consultations being released. Since the announcement of the legislation, OPH has contributed to a number of both federal and provincial consultations in which you have reviewed and approved. OPH will continue to participate in these consultations, and in fact, I'll be providing a bit of an overview of both of the two consultations today. Firstly, in January, OPH put forth recommendations to Health Canada in response to the consultation on the regulations pertaining to cannabis production, packaging, and labeling. More specifically, OPH recommended that Health Canada develop a comprehensive list of permitted cannabis forms. I also recommended that they strengthen the proposed warning labels by including warnings regarding early and frequent use, as well as use during breastfeeding. Also recommended that the packaging be plain packaging to reduce marketing and increase the visibility of the health warnings. Also recommended that Health Canada put in place measures to ensure the safe home production of cannabis, including preparing guidelines and education, with a focus on preventing youth access and decreasing possible health hazards. And finally, OPH has recommended that Health Canada continue to invest in research for safe amounts of THC in product forms and investments in health protection and early identification and treatment. Secondly, this last week, OPH's recommendations to the provincial government regarding retail were circulated to you, and these are before you for your adoption. OPH's main recommendations include that the Ontario government establish a program that monitors employees' compliance with ID checks, establish minimum pricing based on THC content, as well as index pricing to inflation. Also recommended that establish hours of operations that balances the need to reduce access to the illegal market with the need to prevent over-availability and increase consumption, as well as that they demonstrate their accountability to promote social responsibility by publicizing their compliance with provincial legal obligations. Finally, OPH also noted that there are health and social concerns with the online sales of cannabis. Despite the proposed safeguards, online sales provide increased access, remove point of sale education, and increase potential enforcement challenges to ensure that the product does not end up with minors. As such, there is a need for long-term commitment to evidence-informed decisions that protect health, minimize harms, and prevent the normalization and commercialization of cannabis use. To reduce possible community harms associated with the legalization of cannabis, OPH has recommended to all levels of government that a public health approach be utilized. This approach would include ensuring that there are investments in health assessments, surveillance, and research, investments for health promotion and prevention activities, that there are sufficient health protection measures put in place. This would include measures to reduce marketing, to protect youth, and to reduce secondhand harms of cannabis use. And then finally, to ensure that there are sufficient supports for early identification of problematic use and treatments for those who use it. Locally, we know that despite cannabis being illegal, Ottawa residents are using cannabis. Approximately 15% of adults have used cannabis in the past year. 35% of students in grades 11 and 12 had used in the past year. In this past December, OPH commissioned a third-party survey to assess Ottawa residents' knowledge, attitudes, and behaviors pertaining to cannabis. Information from this survey is summarized in document 3 of this report. Information from the survey will inform our programming and public health education to Ottawa residents. From this survey, OPH learned that approximately 85% of individuals who were qualified as non-users, that is, people who have not used in the past year, indicated that they were unlikely to use or try after legalization. Similar to other substances, there are health harms from cannabis use. Most notably, there are cognitive effects, as it can impair one's ability to remember, concentrate, pay attention. It can also impair one's ability to drive safely and operate equipment. Smoking cannabis is also detrimental to one's lung health, as cannabis smoke contains the same harmful chemicals as tobacco smoke. Cannabis can also lead to addiction, both psychologically and physical dependence. There's also significant health effects for youth. When cannabis is used at an early age and frequently, it has shown to cause changes in brain structure and function, which may be permanent. And while the link between mental illness and cannabis use is still being established, there is evidence that cannabis use increases the risk of developing psychosis or schizophrenia. And finally, use during pregnancy has been associated with low birth rate. In a lead up to the legislation, OPH has developed an approach that seeks to prevent cannabis use, particularly among youth, encourage low-risk use, and ensure supports to reduce or quitting for those who wish, as well as to protect residents from secondhand effects. This approach includes health promotion and prevention activities, which is going to be largely focused on youth and ensuring that public education is to youth and that they have the correct information. We're going to be working with schools, police, local addictions agencies, and youth-serving agencies. On the slide's actually a picture of our most recent joint planning session with these groups in regards to health promotion activities. We're also looking to ensure that there's health protection. We'll be working with community agencies to further protect residents from harms from cannabis use, should there be any gaps in the legislation. OPH will also be working with partners to support and promote local services that address problematic use. And finally, lessons learned from Colorado indicated that there was a need for ongoing surveillance, which would include monitoring and analyzing cannabis use and health outcome assessments to inform programming and policies, as well as to understand the health and social impacts of legalization. And finally, OPH's future work will include continuing to provide input into provincial and federal consultation, as well as collaborating with partners to seek opportunities for health education, protections, and surveillance. Thank you.
Thank you very much, Ms. Connolly, for your presentation. Any questions or comments? Member Taylor?
Thanks very much, Mr. Chair. One question, but I always start by saying every time this comes up, I think legalizing cannabis is a really, really bad idea. That being said, I'll now ask my question. I understand every single one of the feedback points that we're giving. The one I don't really understand, the one I need a little clarity on is why are we suggesting or what do we care about the pricing? I guess is the question. That was one of the points in the slide. I get everything else about the the promotion aspects, the packaging aspects, the making sure that there's money in the stream there to ensure that we're educating. But what about the pricing structure is of relevance to us as a health agency?
From a health agency, some of the work that we've been doing in research, so most of our recommendations come from lessons learned from other jurisdictions or tobacco or alcohol, and what we know is that pricing, changing the prices can actually influence people's uses of it. So from tobacco, they've indicated that while if you ensure that you need to inflate to increase it to inflation, it reduces youth access. So it's actually trying to reduce youth using cannabis by increasing and adjusting the prices as such.
So we're essentially just counseling the government, make it expensive or not so cheap that people are likely to just put it within kind of financial reach of, I guess, kids working part-time jobs. Is that what we're trying to say? Price it so it's more expensive?
Well, where we seek to find a balance, which is a bit different than the tobacco and alcohol, is that we're needing to find that balance between reducing the access to the illegal market while also making sure that the system in place right now can be sustained and ensures that you're not increasing opportunities for youth to get it, to access it. So there's certain populations that we're looking to have reduced access, and youth is one of the biggest ones. And the research from the tobacco was that with increased prices to tobacco products, there's a decrease in youth use.
Okay, thank you.
Thank you very much. Member Tilley.
So I found it to be an excellent report with great recommendations, and I don't know if this is one for you, Jillian, or maybe one for Dr. Etches. Are other medical officers of health from across the province, other boards of health perhaps, putting in such recommendations to Health Canada, very similar recommendations like this, sort of a warning bell?
We are part of an Ontario Cannabis Collaborative, and we often connect in with there's about 36, so all 36 health units are on it. Whether all of them have the resources to be putting forward the recommendations each time, we do consult in with them, and we're ensuring that we're aligned with them on most of the recommendations. So Health Canada is hearing similar messages from most of the health units.
Thank you very much. Member Fleury.
Merci, Monsieur le Président. I won't be long. Can you clarify that the intent of that consultation from the province relates to the CCBO stores, which are specific to recreational use and not including medical use?
Correct. At this time, the medical use is still going to be through the federal government, and the recreational use is through the provincial government.
Okay. Has the federal government made up their mind on how the sale of medical marijuana will happen after July 1st?
At this time, they're still talking about an online distribution model.
Okay. And then I came across information recently that the province will not only apply the Smoke-Free Ontario Act to the cannabis use, but will also apply the Liquor Act. What that means, and I'm speaking now as Chair of Ottawa Community Housing, is all the applicable legislation relating to public spaces will apply, which I'm fully supportive of. It aligns with the Smoke-Free Ontario Act. But further to that, it really pushes the use in a personal dwelling, in a personal unit, which from a landlord perspective can bring challenges. Even if we were to look at restrictions, which I believe we can under the Act, then we put the individual user in a situation where legally where do they consume the product. So I'd love to hear maybe your thoughts on where that's heading.
Where we're at right now is that the consultation that you outlined is the Smoke-Free Ontario Act that's due at the beginning of March. And at this time, we're just still doing research and evidence, and as well as seeking to have consultations with community partners such as community housing to ensure that we're putting forward recommendations that are a good representation of the challenges that a number of our partners may face. We do recognize there's a need for a balance with people smoking in their or using in their home versus others' exposure to smoke, and so that's something that we will be researching and looking at. And similar to the other consultations that we've been doing, we will be sharing that with you prior to submitting.
Thank you very much, Member Lakin.
Thank you, Mr. Chair. Thanks for the report, and in receiving the report, I had some reservation in understanding, or some difficulty in understanding the focus of the health messaging that comes as part of the OPH approach to reduce harms from cannabis use. And it's unlike me to express this, but I have some reservations, and I wanted to express some caution about the intention to focus on health messaging with the goal of preventing initiation of use and normalizing use. I don't think there's any doubt that legalizing marijuana is going to normalize use, nor is there any doubt that it's going to increase use. And so my question is whether in creating the health messaging as part of the harm reduction aspect of OPH is thinking about why we wouldn't go for a more targeted approach to the health messaging, specifically with respect to responsible use, messaging around risks associated with impaired driving, risk associated with pregnancy, and so on. So my question is, the goals of the messaging appear to be quite broad and perhaps going to be facing a daunting task in the face of the fact that normalization and use will increase, and why a more targeted messaging wasn't proposed.
And I think it's a broad stroke what's presented in the report, and what we're going to be looking at is similar to our work with the other substances, where Andrew's at, is looking to work with people where they're at on the spectrum of substance use. And so we're going to be, large focus for youth is actually going to be the low-risk cannabis guidelines. And they have 10 recommendations, and our initial recommendation would be to youth, and that's like from 10 to 13, 14 is don't use. And then the next thing is if you're going to use safely. So similar messaging that we've been promoting for the last year on our opioids. And so we will be looking at doing targeting messaging for youth with the ultimate goal of reducing use, decreasing initiation, and trying to denormalize it within the context of the low-risk cannabis guidelines. And those guidelines have about 10 recommendations in there. And we're looking at, we will be doing targeted within, understanding where youth are on the spectrum of substance use and providing targeted messages to them with that. On the note of the impaired driving, we will be working with Safer Roads Ottawa on doing a broad public messaging campaign focused on impaired use and driving. So the broad messaging that we have at this point will be focused largely on cannabis use and driving, but the targeted messaging will be in the schools with the youth and youth-serving agencies.
Thank you. One of the reasons I was concerned about the broadness of the health messaging is how difficult, if not impossible, it would be to measure the effectiveness of the messaging. And my concern would be that if one was to measure usage and normalizing before and after, one would think your messaging was ineffective because those two variables will go up, not because of your messaging, just because of the legislation. So as part of the messaging approach, how are you thinking of evaluating its effectiveness, given that it's quite broad?
I appreciate that, and I think one of the things that we're going to be looking at is the Canadian Centre for Substance Use and Addictions actually did a survey in about 2000, and they did 2013 and 2016, and they looked at what are youth perceptions of cannabis, and what's the best measures and best interventions to be reaching youth, and we'll be using that as a launching pad for most of our work. And so determining in facts, determining our effectiveness in this, we're going to be looking at, did youth actually get the message? Are they getting the different messages out there? Because I think largely what this research demonstrated, that youth kind of were saying a large point is that people are telling them, just don't use, just say no. And what you're hearing with the cannabis guidelines is that we're going to be using a different messaging, a bit more varied message. And so seeing even just is that information getting through to the youth and making sure that they have the skill sets to be actually refusing drugs, peer pressure, and whatnot. So looking to see whether we're going to be doing some training with intermediaries. Do they have that information? And then going back to the youth and seeing, are they getting that varied message? When you're looking at developing, obviously, like new health promotion messaging and getting that out to the youth, where there's largely for so long as a result of it being illegal, the message has just been don't use. We're actually seeking just to shift it ever so slightly. So as a starting point will just be, is that message getting out? And then looking at whether people are reducing or changing their initiation. And that's one of the measures that we'll be looking at. And some research from CASS, the Canadian Centre of Substance Use, has demonstrated that youth, once they have the messaging, are actually changing their behavior patterns. Not that they're not using, but they're using safer methods, or that they're changing their date of onset.
I could just add, I think the survey information that's included in your board report shows there's a lot of misunderstanding about the effects of cannabis use, and so we can repeat those kinds of surveys. We can look if people still have misunderstandings, as well as what Jillian's describing, and actually looking at behavior. I think we learned with tobacco, you're right, health messaging alone is not going to change the landscape. You need the whole spectrum, and this is what we're putting forward, a public health approach that includes the health protection measures as well as health promotion, that uses a foundation of surveillance to know what's happening.
May I have one just to follow up? Would OPH consider promoting vaping as part of its health messaging and partnering with others to promote vaping for the purposes of consuming?
I don't think that we would come out and say that we would promote vaping, but the low-risk cannabis guidelines indicate that you were recommending lower methods, lower risk methods, and vaping is one of those.
Thank you very much, Member Lakin. Member Chernyshenko, please.
Yes, thank you. I've certainly, over quite a number of years, reached the conclusion that legalization and the path we're going down now is necessary for one set of reasons, while at the same time continuing to have very serious reservations about the health impacts, and your listed them for me. So you even added a few that I hadn't thought of, and so I think this question of messaging is going to be absolutely critical. And what we're hearing really from amongst us is the message, don't use for people who are going to use isn't going to sell, particularly when there's peer issues involved, but to do so knowledgeably and as safely as possible. And so that's actually the one side, that the supply that they are getting be something that's legal and in some way controlled and certified, helps to deal with one set of contaminated or the great unknown of what is it you're actually consuming in the first place. And so I look forward to participating in this ongoing refinement of the messaging. I'm really observing, purely anecdotally, just in the past couple of years since the word on the street, so to speak, is it's legal. Well, it's not yet, but it's going to be, and it's safe, and you can do it anywhere. And so we are starting to see. All you have to do is walk down the street, and even the nicest residential neighborhoods, maybe particularly the nicest residential neighborhoods, and you smell it in a way that I didn't smell tobacco before. And so there's something about the quite open consumption in public spaces, in public parks, that we'd even moved away from with tobacco, and almost have to sort of grab this bull by the horns and bring it back. And I think that's really the key message is. It's not any safer than it was before it was legalized. In fact, we know a lot more about it now, but we're not about to try and convince you, other than below a certain age, where we'll still try, not to start or not to start yet, and to focus on improving just the general literacy of what substances do to your brain, do to your body. That's clearly a comment, not a question, but thank you.
Anyone else? Member Kakish.
Thank you, Chair, and I appreciate that the submission is sort of meant to remain vague, but one of the reports that have been out recently or has been discussed is the idea of the province consulting about public lounges. And it seems like, and I don't know, you may have more insights than we do, that is the direction that they may be interested in going in. I find that very outrageous and contradictory based on what we've been doing in the last little while. And you just mentioned in your verbal update that the hookah establishments have dropped that report. So I don't know, first of all, why is that not sort of mentioned in the letter? And I think you have spoken against that, if I'm not mistaken, from what I've seen in reports, but maybe you can clarify that for us. But I think it's a huge contradiction for us to be sort of encouraging that or being okay with that when we've just done all the work we've done in terms of banning smoking indoors. And obviously there's going to be an issue about where do you smoke it and that, but where do you smoke cigarettes and where do you smoke hookahs now, right? So I'm interested in your perspective on that. What's the OPH position on that, given all the work that we've done to eliminate smoking indoors?
Two questions. So the first one, the reason it's not included in this is that there's actually a provincial consultation coming up that's due at the beginning of March. that actually asks about the proposed public usage regulations under the Cannabis Act, and so we'll be putting forward recommendations at that time, and then that's when you'll see our fulsome discussion on it. And where we have to balance is where Councillor Fleury was bringing up that balance between lounges, personal dwellings, and whatnot. So we are gathering the research and the evidence on that. But we also have put forward recommendations in the past to both the federal and the provincial government, a broad ban on public usage of cannabis. That has been one of our recommendations in the past. So.
Okay, can you explain that second point? What do you mean? Say that
So when the provincial government came forward in the summer and was asking about their proposals, they had some really broad pieces of it, and we put forward recommendations at that time that there should be a broad public ban on cannabis use at that time. And since that time, the province has now come out with consultations on the next level of legislation, which is the regulations, and that's where you're hearing about the public lounges. So we had recommended a broad piece, and now they're getting into the kind of minutia, detailed points of it about, social housing, lounges and whatnot. And in that consultation, we'll be looking at that in that level of detail and examining the evidence and putting forward recommendations at that time.
Okay, so we don't have a position right now? You're not against indoor lounges for
No,
cannabis?
I think it is a complex environment where we're trying to ultimately reduce use and also make it safer for people to use. So with the legalization, so it's something we haven't landed on yet. We will bring forward that position to you before we submit it. So it'll be later this month.
But you don't see that as a contradiction, like even being on the fence at it today? I understand the federal government has a direction, but you've recommended to us just, in the past year or two to ban it for hookahs and for other things.
Yeah.
So just on that perspective, do you not see it as a contradiction?
I am concerned about the consumption of cannabis, and I'm concerned about the smoking of cannabis indoors. It's not good for people to breathe smoke, and so it's not good. It's not good in a workplace. So I do have concerns. What we're looking at is the details of what could be proposed by the province. What's the framework they're looking at to make it lower risk indoors? People have raised this as an issue of equity and also a concern for others within a confined building. So that's an issue of secondhand smoke, and are they proposing things where there's ventilation? These are all variables. You're right, from a public health perspective, we'd like to see no smoking of cannabis. But we have to be realistic, and so these are the things that we're going to come back.
Okay. Yeah, because these were the points that I remember the hookah industry was here and they said, we'll put the ventilation systems and we'll put the fans. So, my preference is, and you'll come up with your own recommendations, but it would make us look like fools if we're going to come back and say, yeah, you can do it publicly when we've just shut down all these places, right? So that's all I'm saying. I think we need to be cautious. I appreciate that the direction's coming from the federal government, but I think as a Board of Health, we also need to be consistent in what we're doing and not speaking out of both sides of our mouth. So that's my point on that today. Thank you, Chair.
Thank you very much, Member Kakish. Anyone else? Not if I'd like to make a couple of comments. First of all, like Member Taylor, I'm concerned about legalization of marijuana also. I think it's a little too soon, a little too early, and I think the parameters haven't been laid out properly as of yet. My concerns are obviously not only from an enforcement point of view, but also from how do we educate. I know we did a great job in tobacco education, but tobacco education took us a number of years to get there. Here we are, we're maybe facing the same problem or similar problem going forward, especially when you talk about smoking marijuana, and where and when can you do that. The other concern I have is the fact that each province is given its own mandate to work within their own jurisdiction. How similar will those jurisdictions be compared to the city of Ottawa? We do have borders on both sides of our city. That's a concern for me, that we say one direction and somebody else next door takes another direction. That's going to create problems for us. The other thing is the fact about the payments or the cost to all of this. Nobody's defined that other than the fact that the federal governments have said this is what we want in terms of percentages. but the province haven't been giving any direction to us, as well as from our perspective, and not only from a public health perspective. I know that's what we're talking about this evening, but there's also the enforcement perspective that I know the OPS would be concerned with, as to how do we get that program in play, and how do we do impairment control, for example, on the roadside or wherever that's going to take place. The final point for me is the fact that in terms of what Councillor Fleury was mentioning is the fact that about residential use, between the condo boards, who's going to enforce that? Between the landlords, who's going to enforce that? Is there going to be an enforcement? And those are some of the concerns that I have as the chair of this board. Although I do respect the work that Ms. Conley and her team have done with these directions that we're providing this evening for the health part of it. And I do look forward to the next report that's coming up probably the end of March or middle of March to us. But having said that, I just wanted to put my position on the table to say, look, I'm okay with these directions going forward. Will I be there at the next time we put out more direction? They must include some of the points that the table has mentioned in this evening's presentation. So thank you for that. And that the Board of Health, the recommendation is that the Board of Health for the City of Ottawa Health Unit receive. Okay, so we go to the motion first, Madame Pinal.
Whereas page 5 of the report titled Preparing for the Legalization of Non-Medical Cannabis speaks the number of regulatory proposals that accompanied the recently passed Provincial Cannabis Act, one of which closes on February 7th, and whereas on February 3rd, 2018, board members were circulated Ottawa Public Health's proposal submission to the Ontario government on proposed regulations relating to cannabis retail and distribution. Therefore, be it resolved that the Board of Health for the City of Ottawa Health Unit receive the proposed submission to the Ontario government on proposed regulations relating to cannabis retail and distribution, circulated to board members on February 3rd, 2018, as document 4 to the report titled Preparing for the Legalization of Non-Medical Cannabis, and be it further resolved that the Board of Health for the City of Ottawa Health Unit adopt as its formal position the proposed submission to the Ontario government on proposed regulations relating to cannabis retail and distribution as outlined in document 4, and direct the board secretary to submit it to the Ontario government in advance of its deadline of February 7th, 2018.
Thank you, Member Pinnell. Is that motion carried? Carried. Thank you. So now coming back to the recommendation of the report. Item 1, receive for information the Acting Medical Officer of Health submission to the Health Canada consultations regarding the federal government's proposed approach to the regulation of cannabis as outlined in document 1 attached. Item number 2, adopt a formal Ottawa Board of Health position on the regulation for cannabis production, packaging, and labeling based on the recommendations outlined in document 1. And 3, receive for information Ottawa Public Health's plan to reduce the harms for cannabis use. We're going to have to, if we carry this item, it's based on the amendment that was just passed by Madame Pinnell's motion. So is this report carried as amended? Received? Thank you. Okay, moving on to item number 6 about healthy eating, active living, marketing of unhealthy food and beverages, next steps. And back to Ms. Connolly.
Thank you. I'll just wait for my team. Thanks. So with me today is Sonia Jean-Philippe and Emily Spencer, who are both dietitians with our Healthy Eating Active Living team. So this past spring, as you recall, you directed OPH staff to undertake a consultation on marketing of unhealthy food and beverages to children. The purpose of the consultation was to gain a greater understanding of Ottawa residents' perspective on this issue, as well as seek input from Ottawa residents, community partners, and stakeholders regarding the potential for reducing marketing of unhealthy food and beverages to children. I'm here today, further to the report before you, to present a summary of the findings from our consultation and to seek your approval for our work moving forward. There are a number of health impacts from marketing. For instance, marketing can impact a children and youth's health and behavior. Children's preferences, purchase requests, and consumption patterns are influenced by marketing. Foods children eat and ask their parents to buy can be influenced by marketing. Marketing can also normalize unhealthy behavior while encouraging greater consumption of unhealthy eating behaviors. And finally, food and beverage marketing uses multiple messages in multiple channels and focuses on branding and building relationships with consumers. As such, various marketing techniques allow brands to reach children and youth in many ways all day long. An important note is that marketing is one element that we are seeking to impact to influence our environment, as no single intervention on its own can solve the obesity epidemic and the prevalence of chronic diseases. A collective approach involving a multitude of interventions in many sectors will be required to improve the health of our children. Currently, there are a number of organizations and governments exploring opportunities to reduce marketing to children and youth. Two recent federal actions include, in December, Health Canada released a report summarizing the results of their consultation on restricting marketing of unhealthy food and beverages. At the board meeting in September, OPH's response to Health Canada's consultation was presented. In addition, Bill S-228, an act to amend the Food and Beverage Act prohibiting marketing of food and beverage directed at children, has moved to second reading in the House of Commons. At a local level, OPH undertook a community consultation in which 1,500 people participated through various methods. 1,000 people participated in a bilingual online convenience survey. 400 people were surveyed through a randomized telephone survey. Focus groups with school boards, childcare representatives, and youth were conducted. Webinars with focus groups with sports organizations, businesses, and industry were also conducted, and meetings with city department representatives. On this slide is actually a picture from one of our youth focus groups. It's the youth's representation of marketing. What we heard from residents was that, and overall, residents agreed that this is an issue. Overall, we saw that about 90% agreed that marketing of unhealthy food and beverages targets children and youth, affects their food and beverage choices, and causes health problems. Furthermore, approximately 75% agreed that marketing of food and beverages directed at children and youth were mostly for products that were unhealthy. They also agreed that marketing impacts what children ask their parents to buy. We also heard that residents in large part supported policy actions. 70 to 80% supported limiting marketing. 80 to 90% supported reducing availability of unhealthy food and beverages. While there was large support from residents for policies, there were a number of issues that were raised from stakeholders. These include a possible loss of revenue from the restriction of marketing, that marketing was a small piece of a much larger issue, that education about the impacts of marketing to children and youth was much preferred rather than policies. And finally, the challenge of actually defining what was unhealthy food and beverage was raised. As a note, there was limited engagement from businesses, sports, and recreational representatives. As such, as part of our ongoing work, we are seeking to continue to further engage them. Based on the input that we heard from the residents and our stakeholders, we put forward actions moving forward, which include two focus areas. One is community action. OPH is going to be continuing to engage the community with the aim of building consensus to influence policy. We will seek to gain a greater understanding of the issues raised by stakeholders and opportunities to mitigate these possible issues. And we will continue discussions with partners about the feasibility of various policy options outlined in the report. We're also looking to support federal actions, most notably by exploring an opportunity to pilot an initiative to support their actions. The federal consultations will also be included. And that concludes my presentation. Thank you.
Thank you once again, Ms. Connolly. And any questions or comment? Member Taylor, please.
Thanks very much, Chair. And I think as the hour is creeping up on us, brevity is going to be rewarded, so I'll be brief. I wanted to say thank you to the team for the work that they've done on this to date. I think, we're on the path now. There's a lot more to be done. I think we'll probably discover what that is as we start to get the information out there a little more. The one finding I really did find surprising was that more people favor actually banning the product or reducing availability of the product than do limiting the marketing. So from a democracy standpoint, that tells me people would rather ban the product than ban the talking about the product. So that was interesting. But thank you to the team for doing this, and I think we're on our way.
Any Member Kakish?
Thank you. And just a question about something that came up last year when this report was before us in terms of the city facilities, community centers, et cetera, where we're in contracts or the city is in contract with Pepsi, Coke, whatever the company is. So has there been any progress in terms of, are you talking to, for example, sponsorship in Parks and Recs about those agreements and how the future, when those contracts or agreements are up, is going to look in terms of sponsorship opportunities? Has that been on your radar yet?
We did have conversations with both our economic development and our Parks and Rec colleagues, and those were exactly what we were discussing and some opportunities for that. So that's going to be part of our ongoing discussions, with the most notable discussion about feasibility and the loss of revenue. Those are two elements that we're needing to discuss as an ongoing piece for that.
Okay. And how was the, we know the Cokes and the Pepsis were coming in, and sort of one of the main stakeholders in this discussion that was, sort of worried about it, or how we were moving forward with it. How are they at the end of all of this?
So as part of the ongoing, so we invited the Canadian Beverage Association as well as representatives from Coke to participate in our webinars as well as our in-person consultation. And while members did sign up, they didn't actually come and participate. However, we did continue the discussion with them. So prior to the report being finalized, and once we had our results back, I had a conversation with the president actually of CBA in terms of where we're going and our recommendations going forward. And at that time they hadn't flagged any issues that they said. So I think that there's just ongoing discussions in this area.
Okay, thank you.
Thank you very much. Anyone else? Seeing no other question, thank you very much for the presentation once again, Gillian, and to your team. And can we go back and receive the report? The recommendation is receive for information the results of the consultation for marketing of unhealthy food and beverages to children and youth in Ottawa 2017 as detailed in document 3, and approve Ottawa Public Health's 2018 approach to marketing unhealthy foods and beverages to children and youth as described in this report. Is that carried? Carried. Thank you. Moving on to our last item for this evening, item number 9, and which is the options for recruitment, selection, and appointment of medical officer of health. Just a statement from me on this. Colleagues, I had asked the board secretary to include this item on tonight's agenda because I know we all appreciate the importance of moving forward on the issue of selection and appointment of our next medical officer of health as efficiently and as effectively as possible. I recently consulted with the city clerk and solicitor and reviewed the Ministry of Health and Long-Term Care's guideline with respect to the appointment of a medical officer of health in preparation for this meeting. In doing so, two things became clear to me. Firstly, that the selection and appointment of a new MOH is a very important responsibility for any Board of Health. Secondly, that the responsibility for this process rests squarely with the Board. Although Health Unit and City staff can provide us with information about the legislative requirements, ministry guidelines, and past practices, they cannot provide us with advice or make specific recommendations on how we should proceed. We need to do that work ourselves. Therefore, I've asked staff to prepare a high-level presentation on exactly the topics I just mentioned. The legislative requirements, ministry's guideline, and past practices related to the selection and appointment of the medical officer of health. I'm also proposing that after we hear the staff presentation, we then consider establishing a sponsor group comprised of 3 board members to move forward on this important initiative. The sponsors group could be tasked with the responsibility of further exploring the options available to us, along with their implications, and reporting back to the board with a recommended approach at our next meeting in April. To that end, a motion has been circulated for your consideration, and we can discuss that after the presentation this evening. So now it's my pleasure to turn the floor over to Ms. Valerie Biottoletti for the presentation.
Merci, Monsieur le Président, membres du Conseil. Je m'appelle Valérie Biettelot. Je suis temporairement affectée au Santé publique Ottawa et mon poste, je suis ici pour vous parler en tant que mon poste de conseillère juridique à la Ville d'Ottawa. Good evening, members of the board and Mr. Chair. My name is Valerie Biettelot. I am Acting Program Manager with Ottawa Public Health in a temporary position, but I'm here to speak to you tonight in my substantive position as legal counsel with the City of Ottawa. So, as you've said, Mr. Chair, I will present to you briefly today some information to provide an overview of the board's role in and the legislative requirements for the recruitment and appointment of medical officer of health, and also some of the policy direction that's been given by the Ministry of Health and Long-Term Care, to review the qualifications for a medical officer of health in Ontario, to review past practices for the appointments, and to describe some of the options that are open to the board to move forward on this file. I'm manning both computers, so you'll have to bear with me, Mr. Chair. There we go. So first of all, as you know, Mr. Chair, the City of Ottawa Act 1999 was amended in 2010 to create this board, the new Board of Health. That amendment deems as well that the board is established under the Health Protection and Promotion Act, the HPPA, which, as you know, is the main piece of enabling legislation for public health in Ontario. With respect to the medical officer of health position, Section 12 of the City of Ottawa Act provides specifically that City Council will appoint the medical officer of health in Ottawa. From a practical perspective, what this means, though, that this Board of Health would make a recommendation to City Council. That recommendation would rise to Council for approval. The final approval rests with Council. The HPPA also prescribes that certain requirements must be met for a medical officer of health. So, for example, under Section 62, the medical officer of health for a Board of Health must be full-time. That individual must be a physician, must hold the specific qualifications that are prescribed in the regulation under the HPPA, and finally, must be approved by the Minister of Health. So any decision that is recommended by this board to Council and any of Council's decisions with respect to the appointment of a medical officer of health have to be approved by the Minister. Once appointed, of course, the medical officer of health is accountable to this board for the management of public health programs and services under the HPPA and any other legislation such as the Immunization of School Pupils Act, and also reports directly to this board for any matters of public health concern. The HPPA also provides that the board, or the municipality as the case may be, may appoint an acting medical officer of health, which is what this board did last November with Dr. Etches. So I just want to confirm that that acting appointment is in force and remains valid until this board appoints, or this board recommends a medical officer of health, which is then approved by council and the minister. Nothing further needs to be done for that acting appointment. So looking at the specific qualifications for a medical officer of health in Ontario, both the HPPA itself and the Regulation 566 under the HPPA, that regulation is entitled Qualifications of Board of Health Staff, as well as the ministry's policy direction, provide some guidance. So first of all, under these authorities, as I said, the medical officer of health must be a physician. What this means in practical terms is that that individual must hold a current registration for independent practice with the College of Physicians and Surgeons of Ontario, which means that they are able to practice in Ontario. They must also hold one of the educational requirements prescribed by the regulation. Those are either a fellowship in public health, preventative medicine from the Royal College of Physicians and Surgeons of Canada, or a postgraduate degree in public health from a Canadian university or an equivalent non-Canadian university as approved by the minister. The Ministry of Health and Long-Term Care has provided some additional policy direction, and that is that the candidate hold the CPSO certificate for professional conduct. And if the candidate is coming from a jurisdiction outside of Ottawa, that conflict of interest searches have been done. So that represents basically the requirements that are either prescribed by legislation or by policy direction from the minister. I should add that the board is free to add any additional qualifications that it sees fit for a medical officer of health. In Ottawa, the medical officer of health is subject to the bilingualism policy of the city. We know that that policy requires that executives and senior management positions are designated bilingual. So we'll look at some of the recruitment process options. The actual recruitment process used by the Board of Health and by Council are not prescribed by legislation or the regulation, nor are specific timelines associated with those recruitment processes. So it is entirely the Board's choice how it wants to proceed with the recruitment process. As a result, you may want to hear about different options, and we have seen various processes used in the past, both for appointments of medical officers of health, for associate medical officers of health, and for other executive positions at the city. In the recent past, we've seen a range of options, and these can be broken down essentially into three broad approaches. The first one is a competitive recruitment process through an external search firm. The second one generally is an internally managed recruitment process, for example, using already existing public health networks. And then the last one, of course, is the appointment of a person without a competition. So in terms of these three broad approaches, I thought it would be good to give you some examples. First of all, the competition process using an external firm has been used at the city extensively, most recently, for example, for recruiting the city manager. That process is at a cost. An external firm is for a fee. Past examples have shown that that fee can range from $50,000 to $80,000 or so dollars. The length of time of that process can be 8 to 10 months based on past practice as well. I should note there is a precedent with the medical officer of health as well. In 2005, the medical officer of health here in Ottawa was recruited by an external firm process as well. Essentially, that process is what you're used to seeing. An external firm would be retained. They would search for candidates based on qualifications put forward by the board, and they would have a look at what the legislation requires as well. Most often then a short list is drafted, and it is usually a panel of a board or of committee of council that then takes it further with interviews, with the final recommendation being up to council. The second process is an internally managed competitive recruitment process. This type of process has also been used in Ottawa, specifically for associate medical officers of health. Essentially, the way it would work is that with the help of the city's HR department, a posting would be advertised, likely using provincial and national existing health networks. And from there, a short list of candidates would be drawn, and then the same type of process would ensue. This type of process tends to be not as costly. You're relying on city departments to assist you, and tends to be not as long as well, usually 3 to 5 months. The last process available to you is that a particular candidate be appointed without a competitive process. This has occurred in Ottawa as well, in 2008 for the medical officer of health position. It also occurs at the City of Ottawa with general manager positions as well. In all cases, though, it's important to remember that regardless of the recruitment process that you choose, the legislative requirements and qualifications for the medical officer of health would have to be in place. So I thought we would look at the specific ministry approval process. Once a preferred candidate is recommended by the board and then the matter rises to council for approval, following council's approval, council must send a record of its approval together with a documentation package to the ministry for an internal review by the ministry. That is to ensure that all the prescribed qualifications have been met and all the steps have been followed. I don't have a length of time to tell you with precision how long that process takes, but the matter then rises to the minister, and if the minister approves the candidate, the decision is in writing. I think going forward in 2018, the board may have timeframes on its mind, given that we are facing a provincial general election and a municipal election as well. In both cases, the board members may want to think about the timelines that those events present. So for example, we know that with the provincial election scheduled on June 7th, there may be some timing requirements. We anticipate that the legislature will dissolve sometime in April. And while that doesn't present a legal impediment to the minister's approval of a candidate that's put forward by City Council, I have no information to give you on whether or not the current minister will be amenable to making MOH appointments during an election process. That is something that the board may want to investigate further. On the municipal side, we know we have a municipal election on October 22nd. The closing of nominations is scheduled for July 27th. What that means is that depending on the number of current elected officials that are running again for re-election, the Municipal Act may intervene and may actually prohibit council from making any appointments of legislative officers after the close of nomination day. So again, July 27th. We don't know what those numbers are yet, but that is something that the board may want to keep in mind as well. So those timeframes may be something that the board wishes to discuss further and may have an impact on the process that you wish to choose ultimately. So Mr. Chair, that's the information I have. I'd be happy to answer questions if you have any.
Thank you very much, Ms. Biatlot, Valerie, and I'll turn the floor over to Member Fleury for the motion.
Merci, Monsieur le Président. A quick motion here to direct a few members of the board to look into the matters presented in front of us and report back. I'll read the motion. Whereas on November 8, 2017, Dr. Israel Levy provided notice of his resignation from the City of Ottawa Health Unit effective January 8, 2018. Whereas at a special meeting held on November 14, 2017, the Board of Health approved the appointment of Dr. Vera Etches as acting medical officer of health until such time as Council appoints a new medical officer of health. Whereas in this meeting of February 5, 2018, the Board of Health received information with respect to the legislation legislative requirements and guidelines of the Ministry of Health and Long-Term Care, as well as options for the selection of and appointment of the medical officer of health. And whereas the selection of the appointment of the new medical officer of health is one of the most significant tasks undertaken by the Board of Health, and whereas the position of the medical officer of health is as head of the Ottawa Public Health Unit makes it important that the board seizes the initiative as it relates to the next steps in this matter. Therefore, be resolved that the Board of Health for the City of Ottawa Health Unit establish a sponsors group comprised of no less than 3 board members, namely Councillor and Director Mark Taylor, Director Peter Tilley, and our Chair Shad Kadri, be it further resolved that the sponsors group be tasked with the responsibility of further exploring the options for the selection of the appointment of the medical officer of health and report back to the board at its April meeting with recommendations on how to move forward. And be it resolved that the work of the sponsors group should include, but not limited to, the following areas: A, timeline implications; B, cost implications; C, precedent for such processes; and D, the potential pool of qualified candidates.
Thank you very much, Member Fleury. And I turn the floor back to the board. Any questions, comments? Seeing none, can we carry that motion? Carried. Thank you. And report as amended with the motion that the Board of Health for the City of Ottawa Health Unit received this report for information and respect to options for the recruitment, selection, and appointment of a medical officer of health, including the timelines and cost implications related to same as outlined in this report. Can we receive that report? Received. Thank you. Okay, moving on. I just want to make one comment before I finish off at the end. The fact that this board took a little extra time discussing item number 4, I think just goes to show the interest of the board in terms of dealing and discussing items that come across our table. So I want to, thank you all for doing that this evening, because it is one of those important topics that we must discuss, and we did discuss fully. And like I said, thank you for doing that. Motion to adopt reports, Madame Pinel.
Be it resolved that the confirmation of the Chair and Vice Chair report, the verbal report by the Chair of the Board of Health, the verbal update by Dr. Vera Chase, Acting Medical Officer of Health, the harm reduction and overdose prevention follow-up report, the preparing for the legalization of cannabis report, the healthy eating, active living, have your say, protecting vulnerable population through restrictions in marketing of food and beverages report, the Ottawa Board of Health, the Ottawa Board of Public Health Funding and Accountability Agreement 2017 Year-End Results Report, the Attendance and the Association of Local Public Health Agencies Board of Health Section Meeting Report, and the item titled Options for the Recruitment, Selection and Appointment of a Medical Officer of Health be received and adopted as amended.
Is that carried?
No.
Carried. Thank you. Notice of motion for a subsequent meeting. I don't have any at the present time. Motions requiring suspension of the rules for procedure. There's none. Inquiries and answers. Any inquiries? Seeing none. And confirmation bylaw, Madame Pinel, please.
Be it resolved that confirmation bylaw number 2018-1, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health and its meeting of February 5th, 2018 be read and passed.
Is that carried? Carried. Thank you. And adjournment. So carried. Thank you very much, and thanks everybody. Thank you staff for being here this evening also.